something out of this, not only in form of education, but also in the form of further collaboration and research on the area and field. I welcome you all, and I wish to call on the first moderator to start the first session. Thank you.
Thank you, Dr. Abdullah, for this kind introduction. It's really my pleasure with my colleague to moderate the first session. Today, we are going to present the first speaker, Dr. Monica Kazushi. Dr. Kazushi is an active researcher in the field of CAR T-cell therapy. She obtained training in famous universities in London, Milan, and Houston. She developed a new CAR-based strategy for tackling different types of tumors. Currently, she is leading the innovative immunotherapy therapies unit at San Rafael in Milan. I think Dr. Kazushi has a lot to share with us. Just if you have any question, please keep it to the end of the session. Dr. Kazushi, the mic is yours. Please, you can start.
Okay. Can you hear me?
Yes.
Yes.
Right. So, thank you for the introduction and thank you for the invitation. So, the main area of research in our lab is CAR T-cell therapy. So today I'm gonna discuss this topic. Next, please. So I'm gonna cover three main areas related to efficacy determinants in CAR T-cell therapy, the development of inflammation-related toxicities, and also the challenges encountered to translate this approach to solid tumors. Next. So we all know that chimeric antigen receptors are synthetic receptors generated by fusing the single chain fragment from a monoclonal antibody with the zeta chain from the TCR complex. And due to this peculiar structure, the advantages of an antibody-mediated recognition, such as independency from MHC restriction, with the advantages of a T-cell-based strategies. And so the possibility to act as a living drug able to expand in vivo and generate immunological memory. Next. Over the years, the basic structure of a CAR has been modified with the addition of co-stimulatory endodomains, alone or in combination, to boost the ability of CAR T-cells to release cytokines and to expand and persist in patients. Next. So today there are 6 CAR T-cell products approved to treat B-cell lymphoma and leukemia by targeting the CD19 antigen, and 2 to treat multiple myeloma by targeting the BCMA antigen. So all products are based on second generation CARs, so including a co-stimulatory endodomain, either the CD28 or 4-1BB. All these constructs have been originally approved for the treatment of patients relapsing or refractory to several line of treatments. Next. However, there is recently in 2022 2 strategies, Axi-cel and Cilta-cel, has been approved in earlier treatment lines in patients with lymphoma and multiple myeloma. And in the corresponding clinical trials, the CAR T-cell therapy has also compared with standard care showing a key advantage in terms of complete response rates as compared to standard care, and also progression-free survival. And in particular, if we look at the cures in lymphoma patients treated with Axi-cel, we can appreciate a progression-free survival of 42% after 4 years of treatment. So meaning that this approach can be curative, at least for a subset of lymphoma patients. Next. However, so it's clear that there are still many patients that fail to respond to this treatment, as in the case of some patients with lymphoma or CLL, and other patients that relapse after an initial response, especially in the case of ALL or multiple myeloma. So it's clear that there is a need to improve this approach, and this can be done by understanding the biological determinants of efficacy. Next. And so clearly, the first key factor is the expression and recognition of the target antigen, because we know that frequently relapses after CAR T-cell therapy are due to antigen loss or down modulation. And now a possibility to face this problem is to apply to target multiple antigens at once or sequentially. Next. So we also know that treatment failures can also be due to suboptimal CAR T-cell expansion, functionality, and persistence once that T-cells are infused into patients. And in particular, expansion is a parameter clearly correlating with the achievement of complete responses. Now, all these features are together referred as CAR T-cell fitness and need to be improved if you would like to improve efficacy. Next. Now, CAR T-cell fitness can be influenced by several factors, CAR-related factors, such as the presence of endocostimulation or CAR design in general, but also by product-related factors. So, for example, the memory composition of the T-cell infusion product, the CD4-CD8 ratio, and also to treatment patient-related factors such as some intrinsic, some T-cell defects that are imprinted by the underlying disease or previous treatment. And also the presence of a highly immunosuppressive tumor microenvironment. But for the sake of time today, I'm gonna discuss the memory, the relevance of the memory differentiation status. Next. So as we probably know, so T cells exist in different differentiation states, where the apex of the hierarchy is occupied by stem memory T cells that possess the best characteristics for adoptive T cell therapy, both in terms of proliferative potential and self-renewal capability. Next. And this concept, next, has been also confirmed in the CAR field, where it is shown that T cells from CLL and lymphoma patients who achieved a complete response are generally enriched with gene signatures that are typically of early memory differentiation. Next. And recently, also were published the results relative to the ZUMA-7 trial, in which it was tested the activity of Axi-cel as a second-line treatment in patients with lymphoma. And it was shown that the frequency, a higher frequency of stem memory T cells in the infusion products is positively correlates with all efficacy parameters, including response rates, but also progression-free survival and in general duration of responses. Next. So the question is how can we enrich these early memory T-cell populations in the infusion product? So one possibility is to genetically engineered CAR T-cells, for example, by overexpressing genes that can promote early memory preservation, or deleting, on the other hand, genes that can promote the differentiation of T-cells. Another approach is the one based on modulating the ex vivo manufacturing of CAR T-cells, and today I'm going to discuss in particular this second point. Next. So indeed, T-cell manufacturing procedures have evolved over time to enrich this stem memory T-cell population. And how? By providing the proper stimulation, which includes co-stimulation, the proper static conformation, for example, using dynabits for stimulation that mimic antigen-presenting cells, and using homeostatic cytokines like IL-7 and IL-15 that can enrich and selectively expand these early memory populations. And more recently, it has been shown that also the starting cell subset matters. Indeed, it has been shown that if we apply this optimized manufacturing procedure to pre-selected naive cells instead of total T lymphocytes, we can further improve the quality of the infusion product. Next. In line with this, for example, in our lab, we have recently compared the performances of 19 CAR T-cells generated from pre-selected naive stem memory T-cells as compared to total T lymphocytes. And we found that these early memory products are more efficient in protecting mice from a second disease challenge, envisaging a better protection also from disease relapse in patients. And this improved activity is associated with higher expansion rates, preservation of early memory, and poor expression of inhibitory receptors. Next. So another factor that needs to be considered is that so all these CAR approaches, commercial CAR approaches, are applied in the autologous setting, where T cells can display some defects that are imprinted by the underlying disease or previous treatments. For example, it has been demonstrated that in different papers that several cycles of chemotherapy can reduce the quality of T cells and can reduce the fraction of early memory T cells. Next. So, and in line with this, since it is known that the T-cell phenotype in the infusion product and in the leukapheresis are strongly correlated, there is an higher probability of deriving products with an early memory stem-like phenotype from apheresis obtained after few lines of therapies. And this has been confirmed by comparing data from ZUMA-7 and ZUMA-1, in which were treated patients after 2 versus 3 or more lines of therapies. And it appears clearly that the frequency of naive cells is higher in the ZUMA-7 trial. Next. So considering that during the manufacturing, also the complexity and duration of the manufacturing can make the T cell older. So in order to maintain them younger, a possibility is also to shorten and simplify the ex vivo manufacturing of CAR T cells. And recently, the results of the T-Charge platform developed by Novartis were published, showing that the 2-day-long protocol, so very short, is superior in maintaining the stemness of T cells as compared to a standard 10-day protocol. Next. Another possibility to overcome patients' T cell defect is moving to the allogeneic platform, where actually we modify with the CAR T cells from healthy donors. And this approach is gaining much interest in the field, also because it would allow to simplify the manufacturing in general, reduce costs, and make the treatment immediately available for all patients. However, to make it possible, there is need to overcome the allogeneic reactions in both directions that can, on one hand, limit efficacy by inducing CAR T cell rejection. On the other hand, increase the toxicity by inducing the graft-versus-host disease. Now, to overcome, there are currently different multiple approaches under investigation to overcome these barriers. Some based on genetic engineering, for example, the deletion of the endogenous TCR to reduce the GUHD potential, or the use of alternative cell sources for CAR modification, for example, the use of NK cells or invariant NK T cells that have an intrinsic lower potential to cause a GUHD. Next. So we can discuss a bit the second topic, that is the inflammation-related toxicities. Next. So we all know CRS. So CRS is a systemic inflammatory reaction occurring a few days after CAR T cell injection, and manifesting in more severe cases with hypotension, hypoxia, and organ dysfunction, especially in response to high tumor burdens. On the other hand, ICANS is a toxic encephalopathy developing a few days after CRS, and in more severe case manifesting with seizures, motor weaknesses, and cerebral edema. So both toxicities have been described with different CAR products and within different tumor types, and in all cases, these toxicities are associated with an early peak of circulating inflammatory cytokines such as IL-6 and other inflammatory mediators. Next. Now, concerning the pathophysiology of these reactions, so both CRS and ICANS are initiated by massive CAR T cell activation and tumor cell killing at the tumor site. But then both syndromes are propagated by myeloid cells that get activated and release high amounts of inflammatory mediators that reach the bloodstream and mediate the systemic toxicity associated with CRS by interacting with non-hematopoietic tissues, and cause neurotoxicity by disrupting the blood-brain barrier and activating an inflammatory response in the CNS. Next. Now, the pathophysiology of these toxicities remained unknown for several years till the development of animal models able to recapitulate this toxicity. And one of these models have been developed in our lab. So this model is based on the infusion of immunodeficient mice of human hematopoietic stem cells before injection with BALL cells and treatment with 19 CAR T cells. And in this model, so the reconstitution of a human immune system in mouse allowed to better profile anti-tumor activity, but most importantly to exacerbate inflammation-related toxicities like CRS or ICANS, because the myeloid cells are the main source of cytokines and inflammatory mediators that are responsible for CRS and ICANS development. Next. So very briefly, so in this animal model, so it's possible to follow anti-tumor responses together with T-cell expansion, while CRS manifests as a violent inflammatory reaction characterized by weight loss, decreased survival rates, and increased serum levels of human inflammatory mediators like IL-6, but also MCP-1 and IP-10 that have been described also in patients. And we have also developed a CRS grading algorithm that allows mice to be stratified into severity categories resembling those used in patients. Next. So these mice, interestingly, also develop brain hemorrhages that in some way are reminiscent of neurotoxic manifestations observed in patients with high-grade ICANS. So these events are strictly related to CD19 CAR T-cell therapy, since they do not occur in mice receiving just untransduced T cells. Next. And as in patients, these events are strictly correlated with CRS severity and an increased permeability of the blood-brain barrier. Next. So nowadays, these toxicities are managed by using, in particular, tocilizumab, that is active against CRS, but unable actually to control ICANS. And we're using corticosteroids that at high doses can have negative impact on efficacy. So there is still an active research of approaches to mitigate these toxicities, like the identification of predictive biomarkers to identify patients at risk of developing severe toxicities that may benefit from an early intervention. The development of other cytokine inhibitors, in particular, I want to mention that blocks the IL-1 pathway and seem to have the possibility to control ICANS, in particular in a prophylactic setting, or the development of strategies to allow pharmacological control of a CAR T-cell activity by using specific drugs like dasatinib, or specific CAR design that can be switched off or switch on at need. And finally, I want to share with you some data on the impact of the memory differentiation also on toxicity development. Next. Indeed, so I've told you that we have recently demonstrated the superiority in terms of efficacy of CAR T-cell products generated from naive memory T-cells as compared to CAR T-bulk. But we have also compared these products in humanized mice to investigate their toxic potential. Next. And surprisingly, we found that these early memory products are also less prone to induce severe CRS in mice, as indicated by reversible weight loss, decreased amounts of inflammatory cytokines, and increased survival rates. Next. And why is that? So it seems that these early memory T cells are less potent than effectors in triggering the myeloid compartment. Indeed, we found a positive correlation between CAR T cell and monocyte activation levels, and we found lower activation of both populations in mice receiving early memory CAR T naive SCM as compared to CAR T bulk. Next. So recently, inflammasome activation in myeloid cells has been linked to CRS development as a consequence of tumor cell pyroptosis induced by CAR T cells that release high amounts of perforin or granzymes. Next. And we found that these early memory CAR products release lower amounts of granzymes and perforin after antigen-induced stimulation. And moreover, we found lower expression of inflammasome-related genes in monocytes co-culture with CAR T cells, naive CAR T cells as compared to CAR T bulk. So, suggesting that this mechanism can at least in part explain why these early memory products are less toxic. Next. In line with these preclinical data, it was recently, in the context again of the ZUMA-7 trial testing Axi-cel as a second-line treatment, it was shown that the frequency of more differentiated T cells, like effector memory or terminal effectors, is positively associated with the incidence of severe neurotoxicity and release of inflammatory mediators. So, meaning that, suggesting that the enrichment of early memory population in the infusion product can be beneficial not only in terms of efficacy, but also to reduce the safety. So this product can be endowed with a higher therapeutic index. Next. So another toxicity that is important to mention is the so-called hematotoxicity. Indeed, cytopenias occur in a majority of patients early after CAR T-cell infusion, but in a significant fraction of patients can persist for several months. And in particular, these cytopenias have a typical biphasic course, characterized by an initial drop within 1 week after CAR T-cell infusion, followed by 3 patterns of neutrophil recovery. So a quick and full recovery, an intermittent recovery, in which patients experience a second decline after initial recovery, or a totally aplastic phenotype. And you can imagine that how these prolonged late cytopenias can increase the non-relapse mortality after CAR T-cell therapy, in particular due to infection. So they are really important. Next. Next. Okay. And so recently, a CAR, the so-called CAR hematotox score, has been identified, has been developed to identify patients at high risk of developing severe hematotoxicity. So this score is based on parameters indicative of a compromised hematopoietic reserve and high baseline inflammation, and is able to better discriminate the patients the more severe cases, so the aplastic one. However, there is still room for improvement, and to do so, it would be crucial to deepen the understanding of the pathophysiology of these cytopenias, in particular analyzing the impact of CAR T-cell therapy on the hematopoietic stem cell pool. Next. So we can move to the last part of this presentation that is dedicated to CAR T-cell therapy in solid tumors. Next. So we know that the great results obtained when treating B-cell malignancies were not obtained in solid tumors, where you can see the rates of complete responses or even partial responses in green was very low, and obtained especially when targeting the GD2 antigen in the case of neuroblastoma. So there is really a urgent need to develop new CARs and new approaches to widening the application of CAR T-cell therapy also to this type of tumors. And to do so there are several factors that need to be considered. First of all, the selection of the target antigen to avoid the on-target of tumor damage of healthy tissue expressing the target antigen. But also the screening of different CAR designs and constructs to ensure an efficient engagement of the target antigen on tumor cells. And lastly, also the inclusion of the CAR T-cell therapy, the proper inclusion of the CAR T-cell therapy in the treatment schedule, so as to benefit from the positive effect of other drugs like chemotherapy on the immunosuppressive tumor microenvironment. Next. So, for example, recently in the lab, so we have identified a suitable antigen to target in the context of colorectal cancer liver metastasis. And to identify this potential target, we applied a rational workflow by analyzing the expression of surface proteins on different tumor and healthy samples. Next. And with this approach, we were able to identify a panel of genes highly expressed in tissue samples. And we also were able to generate a matrix reporting the expression of each of these genes in the healthy tissues. And with this analysis, we were able to identify this antigen, for example, CDH17, as a good candidate, being expressed at high levels in all tumor tissues, but absent from all healthy tissue except the tissue of origin, that is in case is the intestine. Next. So by looking at the online databases, we confirmed that CDH17 is indeed overexpressed in different tumors of the gastrointestinal tract, including colorectal cancer, pancreatic cancer, and stomach adenocarcinoma. However, we really think that the colorectal cancer till now represents the strongest indication for this antigen to start. Next. Indeed, you can see that this antigen is really expressed at high levels in all tumor cells and in all tumor samples, both primary and metastatic. Next. So we decided to develop a CAR T-cell based approach to target CDH17 in CRC, and to do so, again, we proceeded step by step. So first of all, we designed different CAR constructs. we compared and tested these CARs using both in vitro and in vivo assays, and identified some lead constructs, next, showing an optimal activity in xenograft mouse models of CRC. And we tested these lead constructs using patient-derived material. This is another key step. And also we compared the efficacy using different administration routes of CAR T cells in mice. And in the end, next, we also analyzed from a functional point of view the potential for on-target of tumor toxicity against the healthy tissue expressing the target antigen, that is the healthy intestine. And luckily, we found that a good reactivity of CD817 CAR T cells against tissue slices derived from CRC samples with no reactivity against tissue slices derived from the healthy colon. And we think that this is due to the fact that in the healthy colon, CD817 expression is restricted in the lateral junction between epithelial cells, so in a location that is not accessible to CAR T cells. In CRC, this tissue architecture is lost, and CD817 become expressed all over the cell surface. Next. So even once you have, if you have identified a suitable target to target one solid tumor, and you have designed a good CAR T cell product, you have to consider that to be effective in solid tumors, CAR T cells need to overcome several barriers. For example, they need to traffic to the tumor site and infiltrate very tight tumor masses. And moreover, they have to work and proliferate and even persist in highly immunosuppressive tumor microenvironment. So nowadays at the research level, there are a lot of strategies under investigation to overcome one of or more of these barriers. So, next. However, I want to focus on one point. So for a CAR T cell to work properly, the first requirement is the efficient engagement of the target antigen on tumor cells, so as to establish an immunological synapse able to activate effector functions in T cells. Next. And considering that in this process, so immunological synapse formation, both antigen accessibility and cell-to-cell proximity are crucial, so we got interested with N-glycosylation, that is the addition of sugar chains to nascent proteins that are antigen for CAR T cells. And indeed, N-glycosylation is usually aberrant in tumors, featuring in particular an increased branching of N-glycans that, for example, can mask the epitopes from antibody recognition. So we wonder whether they could also impact on tumor recognition by CAR T cells. Next. And to cut a long story short, we found that the answer is yes. And we found that aberrant sugars decorating the surface of tumor cells can protect them from CAR T cells, while inhibiting their synthesis can boost efficacy by improving the immunological synapse formation and thus increasing the killing of tumor cells. Next. But also by impeding the interaction between inhibitory molecules like PD-1, PD-L1, thus preventing CAR T cell exhaustion in vivo. So in this model, we analyze the crosstalk between CAR T cells and tumor cells. Next. While more recently, we are trying to evaluate the impact of glycosylation also on the tumor microenvironment that, as said, is crucial for shaping anti-tumor responses in the context of solid tumors. And to this aim, we started by correlating the expression of gene signatures typical of bridge and glycan synthesis with gene signatures associated with the specific tumor infiltrating cell populations in both CRC and PDAC. And strikingly, we observed the strongest positive correlation with the tumor-promoting populations like tumor-associated macrophages, regulatory T cells, cancer-associated fibroblasts, thus linking hyperglycosylation with the establishment of an immunosuppressive TME. Next. And in line with this, for example, we have shown that the in vitro deglycosylation of M2 macrophages can reduce the expression of immunosuppressive genes, resulting in the abrogation of their suppressive activity on CAR T cell proliferation and tumor cell killing. Next. And these results were confirmed also in vivo, where we found that combining CAR T cells with the glycosylating agents can improve efficacy, and again, this is associated with the downmodulation of immunosuppressive genes in tumor-infiltrating immune cells. Next. So we can complete this scheme by saying that glycosylation inhibition can boost the efficacy of CAR T cell therapy, not only by improving immunological synapse formation and preventing CAR T cell exhaustion, but also by reducing the immunosuppressive activity of TME cells. Next. Is finished, so I just would like to thank all my lab at the San Raffaele Hospital, in particular Beatrice Greco and Camilla Sirini for the last part on glycosylation blockade, Rita El-Khoury for the part on CAR T cell fitness and the animal model, the humanized animal model, and then Fabio Cicere and Chiara Bonini for all their support, all our internal and external collaborators, all funding agencies, and all of you for your attention. Thank you.
Dr. Monica, welcome again, and I'd like to thank you for the delightful, sophisticated talk about the CAR T cell therapy. Before we are moving to the next session, I will open the floor for the question from the audience.
Thank you. Thank you, Dr. Monica. In view of the new approval of CAR T cell product for melanoma in the US, do you anticipate that in the coming about 7 years, we will have more of CAR T cells approved for solid tumors?
I think that if you are referring to melanoma, those are TILs actually, not really CAR T cells. I think that in the area of solid tumors, that the CAR T cell product that is more close to the approval, maybe is the one targeting GD2, maybe, because it is the most advanced. But I have to say that in solid tumors, possibly the CAR T cell alone not be sufficient. So it is important to think about strategies to potentiate, combination strategies to potentiate their activity. In particular, I think by modulating the tumor microenvironment, and also by fostering also the establishment of endogenous T cell response, in which CAR T cells can be just the first hit, and then also an immune response can be elicited against the tumors by the endogenous immunity.
I think one of the challenges of CAR T cell is the cost.
I cannot hear.
I think one of the challenges of the CAR T cell technology is the cost. Do you think in the future, when the cost will become less, it will be in the earlier line rather than the later line?
Just the last part of your question.
شو صغير بس طرحي.
My question is directed to the cost effectiveness of this technology. The CAR T cell now it's used after multiple line of treatment in lymphoma or in hematological malignancy or after transplant patient. So my question is if the cost will be less, it will become in the earlier line rather than to be the later line.
Yeah. So I think that surely the costs still represent a bottleneck in this area. So there are at least two indications in which the possibility to apply CAR T-cell therapy has been anticipated to earlier line of treatments. I mean, to decrease the costs, there are several approaches that can be considered. For example, the use of alternative vectors for delivering the CAR, because now, in particular, the CAR are delivered with, for example, antiviral vectors, retroviral vectors that are very expensive. So there are other approaches based on, for example, transposons that can be less expensive. And then there is the great interest in the allogeneic field. Do you know? Because in that case, the possibility to have banks of CAR T cells available to treat different patients, not having to match the product with a single patient, will be another key step for reducing the costs. And I know that in general, I'm sorry, is really working a lot on these approaches, these allogeneic approaches.
Thank you, Dr. Monica, for having you here in the first session of Jordanian Society of Hematology Conference. Thank you again.
Thank you.
Is there any question from the audience? Is there any questions? So no further question. Many thanks for your time, Dr. Monica. Good to see you here in Jordan. Many thanks.
Thank you. Thank you very much.
شو دفع؟
Oh, okay. Can you see me now? Can you hear me?
Yes, we can hear you, Dr. Please.
You heard me, Dr. Naim?
Yes, please. You know, this issue about these, unfortunately, the connection through the hospital, the whole hospital system is down. And I'm sitting on my desk, so I have to join through the mobile now. At last, I got connected with a new link sent to me just now.
Don't worry, Dr. Naim.
So whenever you want me to start, I will start.
Would you like to send your presentation if it's possible?
I sent it to Noor, so maybe she can pull the slides
Yeah,
up.
hi. It's fine. I can present from my side, and whenever you're ready, Professor, let me know so I can share my screen.
Okay. How much time do I have? The same time? 45 minutes?
Okay. Assalamu alaikum. Good afternoon, everybody. Our second speaker, Dr. Naim Shodari. Dr. Naim from King Saudi Arabia, King Faisal Specialty Hospital and Research Center. Dr. Shodari is a consultant in hematology and hematopoietic stem cell transplantation at King Faisal Specialty Hospital since 1996 and the Professor College of Medicine. He is currently the chairman and president of the Eastern Mediterranean Blood and Marrow Transplantation Group. He is American Board of Internal Medicine Board certified in Internal Medicine, Medical Oncology and Hematology. He completed his fellowship in Hematology and Medical Oncology in 1995 at Lombard Cancer Center, Georgetown University Hospital, Washington, D.C. His main interest in malignant hematology, specifically leukemia, lymphoma, and hematopoietic stem cell transplantation and cellular therapy. He is the principal investigator of the Southwest Oncology Group for King Faisal Specialty Hospital and Research Center, and the principal investigator of numerous ongoing clinical trials. He has around 200 publications and abstracts in peer-reviewed journals. Dr. Shodari is the Congress Chairman of King Faisal Specialty Hospital, Soho,
annual Hematology Congress in Riyadh, King Saudi Arabia, and a member of organizing and scientific committees of numerous national and international meetings. Dr. Chaudhary talk will be about updates in the management of CML. Dr. Chaudhary, the mic is yours.
Thank you very much, really, for such a nice and detailed introduction. So what I was asked to present something on chronic myeloid leukemia as a TKI resistant or intolerant and the unmet needs when you start failing 1 or 2 lines of therapy. So essentially my talk will be when people do fail 2 lines of therapy, and that's where the unmet needs come, because there are some drugs available. Which one is better than other? What will be the drug available that can provide a better outcome? So let's see. Next slide, please. Next slide. Okay, so these are disclosures, not too much, but this has no conflict for today's talk with it. Next slide, please. So the current status, we have about almost 6 tyrosine kinase inhibitors, the first, the second, the third generation approved. 4 of them are actually at the front line, like imatinib, nilotinib, dasatinib, and even bosutinib. There is high response rates and low rates of transformation. So the good news is that the medications has worked, and there is almost greater than 90% overall survival at 10 years from these TKIs. Now, since we have more and more tyrosine kinase inhibitor, the standard practice has also evolved into providing patients the opportunity to go for a treatment-free remission. And of course, once you start doing this, there is a treatment value cost benefit if overall survival is the goal. So if the overall survival is the goal, how long do you continue TKIs? Can you get some people off the therapy and successfully achieve about 40 to 50% long-term treatment-free remission that will reduce the cost to patients who are paying out of their pockets or even institutional resources. And there is, of course, the near normal life expectancy, and patients are aware of this, and that's where you try to maneuver their care throughout their time period that they follow with you. Next slide, please. So among the future perspectives, the most important part is actually the unmet needs in CML management, especially the new drug development, because once you go beyond the 2 lines of therapy, you know that the 3rd line therapy, in case of failure of 2 lines, is difficult to maintain for a longer period of time. So the utilization of tyrosine kinase inhibitors with different mechanism to achieve a specific goal has always been looked at, and people have done research into it. Next slide, please. So the failure rate increases in later lines of therapy. Next, keep pressing. Sorry, can you see me also? Okay. So once you go beyond the 2nd line of therapy, the more successive lines of therapy would actually reduce the chances that you may remain in remission for a longer period of time. So each successive, once you fail the first one, the second one may keep you for a shorter period of time. It may provide you a remission for a few years, 2 years, 3 years. It's not going to be like 5 or 10 years that you had already achieved with the first line therapy. Next, please. So in the CML current status, the competitive ATP binding TKIs have dramatically improved the survival outcome. We all know that. But some patients do develop resistance and intolerance to these drugs. And patients who develop treatment failures or intolerance have the worst outcomes, especially with the 2 lines of therapy, or if they continue to have intolerance to these drugs, you know that you're moving towards eventually an allostem cell transplantation. And then the remaining treatment options are, of course, few. But sequential use of tyrosine kinase inhibitors is associated with decreased probability of sustained durable response, as I said that before. Next slide. So the new drug development, the utilization of TKI, different mechanism to achieve specific goal. We look into this specifically. How do we revisit a 3rd line therapy in case of failure of 2 lines? Next, please. So this is what the mechanism that clearly is in tyrosine kinase inhibitors works, and they have different mutations that are involved, and they are sensitive or resistant to it. Ponatinib, of course, is a very active drug with least amount of, or none of the mutation that it cannot overcome. Asciminib is a great drug, can overcome the T315I mutation also. And the mechanism of action is also different in these cases. But one needs to understand when you're looking at these inhibitors and the mutations, the resistance, the majority of the resistance is not actually not from these mutations. There is an intrinsic resistance. About 40 to 60% of the patients will actually have an intrinsic resistance where you may not find a mutation, but they do develop resistance, and you keep on asking patients, are they compliant to the medications? And they will assure you that they're compliant, but the response is not optimal and not even, and they go into a failure response with partial responses in these patients. Next, please. So tyrosine kinase inhibitors compete with ATP for the ATP binding site of the protein tyrosine kinase that is made by the BCR-ABL gene, the leukemia cells. Next. From the perspective of allosteric regulation, that's a new mechanism of action that where the new drugs have been developed. So this is the allosteric regulation, just for the understanding, is basically a regulation of an enzyme by binding an effector molecule at a site other than the active site. So if a molecule binds to a site that is other than the active sites, by conformational differences, it is unable, the tyrosine kinase is unable to have an effective driving force to push the bone marrow to produce excessive, the one that is produced by the kinase activity. And so the allosteric inhibition by asciminib is that it binds to the myristoyl pocket of the ABL1 portion of the fusion protein and locks it into an inactive conformation. This is the way it blocks the kinase activity. Next, please. This is just one way to understand that it has a different mechanism of action. So it blocks the myristoyl pocket, and hence then conformation change. It causes the kinase, the ATP binding site also makes it ineffective. Next slide, please. The phase 1 studies of asciminib did show robust responses even in relapsed refractory chronic myeloid leukemias. This is for the non-T315I, for example, less than 2 prior TKIs by 6 months, 33% or had achieved a response and maintained response in 80% of the patients, and that the response was a major molecular response. So an excellent response even in with an optimal response even in 1/3 of the patients by 6 months, and almost close to 50% by 12 months achieving a major molecular response. And the important thing to note is that it maintained over a follow-up period the major molecular responses. And if you come down to more than 2 prior TKI therapies in it, again, there may be some drop, but it's not significant. And apparently, even in those patients, they are able to maintain their long-term remissions if they achieve a major molecular response. If the patients had been previously resistant or intolerant to ponatinib, even those patients in 6 and 12 months, almost 23 to 40% of the patients by 6 or 12 months respectively were able to achieve a remission that they were able to maintain. This is in non-T315I who were actually resistant or intolerant to ponatinib due to some intrinsic resistance. So that clearly shows a different mechanism of action actually helps, where the direct TKI inhibitors like other classes have not been able to work. Asciminib is still able to bypass that resistance and is able to provide a good response. Next, please. Okay. So the ASSEMBLE study, and I was part of this ASSEMBLE study from King Faisal, and we had a good number of patients published in Blood initially, the leukemia, and almost every year we do an update in ASH also. And even in this year ASH, and I'll show it to you, an update on this one. Basically, the trial was designed to give an approved dosage of 40 milligram twice daily as a randomized study of asciminib versus bosutinib in patients with chronic myeloid leukemia, chronic phase patients previously treated with equal to more than 2 TKIs. They were either resistant or they were intolerant. So the patients were randomized 157 to asciminib, 76 to bosutinib. The bosutinib dose was used at 500 milligram, although you could ask why not 400. The reason that 500 of bosutinib is used because that is the dose that is recommended when you use bosutinib in patients who fail first-line therapy. So 400 milligram is only for the upfront. The recommended dose for the failure patients is 500 milligrams. Next, please. So when you look at a patient disposition by the end of the study, the most important thing that one to notice is the patients who completed the treatment. Almost 50% of the patients were able to complete the treatment, while only 10.5% of the patients with bosutinib were able to complete the treatments. And when you look at the week 24, again, the number of patients by week 24 and week 48, a good number of patients were able to maintain with the treatment. Next slide, please. And if you look at the discontinuation, even the lack of efficacy was lower in asciminib. So the patients who were for discontinuation, only 1/4 or less patients were the one who had lack of efficacy in these patients, while in bosutinib was almost 36-37%. Next, please. So the primary endpoint, the major molecular response at 24 weeks for this randomized trial, the common treatment differences adjusted for the baseline major standardized response status. Median weeks to MMR asciminib was 12.7 months versus 14.3. Median exposure was higher with asciminib. Other efficacy points, when you look at the bosutinib and asciminib, it is almost twice the number of patients that you can look at the MMR percentage where patients were able to achieve as compared to bosutinib as a primary endpoint at 24 weeks of evaluation. Next point, please. When you look at the 24, 48 and follow-up of 96 weeks also, it continues to, the most important, the green, if you look at it, it maintains, it increases in the response rate, continues to increase from 24 to 48 weeks, and even at 96 weeks, from 24 weeks to 96 weeks, coming close to at least 1.5 times. While the bosutinib also, there was slight increase at week 96, but the difference is very small among the continuation of improving the major molecular response. Next, please. So cumulative incidence of major molecular response by baseline BCR-ABL1. And when you look at it, the cumulative incidence of MMR increased in both arms, regardless of the baseline BCR-ABL1 IS levels, and was consistently higher with asciminib and then with bosutinib. And this is a long-term, again, the follow-up for these patients. And if you look at it, whether they were BCR-ABL IS was more than 10% or lower, there was a consistent difference between asciminib and bosutinib in the response assessment, and that continued to keep the two graphs apart, consistently showing that the better outcome has been maintained by asciminib. Next slide, please. MMR at 96 weeks subgroup, just to show that the one in the green that favors asciminib, almost all subgroups except a few that were on the baseline, but that was none of the subgroups had an adverse outcome with asciminib. Next slide, please. When you look at the long-term cumulative incidence of major molecular response for a follow-up and longer follow-up at week 156, this has been updated now. It consistently shows almost twice from 23 up to 45.2% week from 156, a cumulative incidence of major molecular response. So patients, the important take-home thing from this slide is basically for people to understand that as a third-line therapy, Obviously, you need to provide a longer-term major molecular response if your patients are not going to be for transplant or have a better quality of life. So it consistently showed that coming close to 50% at the long-term follow-up, patients had achieved a major molecular response, while half the number had MMR for bosutinib. Next, please. Again, follow-up, longer-term follow-up. This was just presented in ASH this year in December. The primary endpoint, as I told you before, week 24, then week 96. Again, almost more than double the major molecular responses rates in 96. And this maintains, when you look at this 3 times, almost or slightly more than 3 times at the end of study treatment of week 156. 10.5% of MMR in bosutinib compared to 33.8%. This is really a great, robust response. And this is good news for all the patients that they are able to maintain where we have always felt that there is an unmet needs of how to continue treating these patients who develop intrinsic or mutational resistance. Next, please. Again, if you look, the major thing is the major, not only the major molecular response, but what is the response assessment when you have a deeper molecular response or MR 4.5, where you actually look for the treatment-free remission. Although I would not recommend treatment-free remission for somebody who has already failed by resistance. So this clearly shows that the risk of progression would be extremely low when patients achieve a deeper molecular response. And in this one, when you look at the MR4, almost not only twice MR4 is doubles in asciminib, but MR 4.5 is almost like 6 to 7 times higher in asciminib as compared to bosutinib. Again, shows at week 96 it maintains its superiority, and at week 156, the longer term follow-up, it continues to maintain its deeper molecular response of MR4 and even of MR 4.5. Next, please. When you look at the progression-free survival, this is what is one of the major endpoints in any study where the long-term overall survival is so good that it's difficult to diverge in overall survival between 2 medications, because there are other options are available, the transplants are available, everything is available. But progression-free survival is one of the major endpoint also. And this shows the graph to be somewhat better, although the p-value was not that significant, but it favors asciminib. Next, please. Looking at all grade, this is one of the things that leads people to use the drug. And one of the things that they want to make sure is that the patients are able to tolerate the medication with the least amount of side effects. And the major issue with bosutinib, as you know, has been diarrhea, but apparently with asciminib, it was excellent. Then the nausea and the rash and vomiting was also less. But when you look at most of the side effects, have been either less than bosutinib or somewhat close, but none of the side effects was something that would stand out persistently as an abnormal or adverse effect of asciminib compared to bosutinib. So this would clearly indicate that if the patient can tolerate, the compliance will improve, and the chances of going into a deeper molecular response will also improve. I mean, you look at the adverse events leading to discontinuation. So bosutinib had 25% of the patients who actually discontinued because of the adverse events, and compared to 7.1% patients who were in asciminib with greater than grade 3 adverse events, 18.4 and 6.4% respectively. Next, please. When you look at the overview of adverse events by the end of the study treatment, again, there seems to be a superiority of asciminib over bosutinib, leading to, from the point of view of adverse events, even in the long-term follow-up. Fatal adverse events are almost equal, but other adverse events leading to discontinuation or adjustment or interruption of the dose also favored asciminib. Not to say that bosutinib is still an excellent drug, it's a very safe drug. Asciminib clearly shows that even a safer safety profile in these kind of patients as a third line. Next, please. Now, this is from the patient-reported outcomes. One of the most important things that from any trial that somebody needs to present is how do the patients report their outcomes. And over here, the green one on the left side of the screen, is the one that favors the patient-related improving the profile of the safety of the outcomes. Superiority is almost all in the pain, fatigue, or nausea, or and you can look at it. It's a long list without me going through it. But from the patient-reported outcomes, asciminib does show superiority in this randomized controlled trial. Next, please. So in conclusion, from the point of view of the development of this new drug and comparing it with a drug that has already been approved as first line, that is bosutinib with equal or better superiority over imatinib, just like nilotinib or dasatinib. So the drug by itself is as effective as other second generations like nilotinib or dasatinib. And when they compare it to asciminib, apparently in this assembled trial, the phase 3 trial, asciminib showed superiority. Now, this is the first controlled study comparing directly with patients who are resistant or intolerant patients with CML, these two drugs. There's no other directly controlled study comparing different TKIs for resistant or intolerant patients with chronic myeloid leukemia. Now, the asciminib demonstrated statistically significant and clinically meaningful superior efficacy compared with bosutinib and a favorable safety profile. And both these endpoints are really important, the superior efficacy and a favorable safety profile, not only from the data collected, but also from the patient outcome. So the assembled results support the potential of asciminib to transform the CML treatment landscape, particularly for patients with resistant or intolerance to more than two prior TKIs. And this is what the major take-home message is, all that we don't have to keep cycling the drugs that we have been there before. It's a safe drug which has shown superiority over bosutinib, which is equally effective like nilotinib or dasatinib, and probably better than imatinib anyway from all these three drugs. So instead of cycling, if you have a patient that you feel may not benefit from another TKI of the same class and may have the side effects or the safety profile may not be good, one can select asciminib. And I will show you some cases just now, right after this. So BCL-1 remains a key driver of CML in third-line patients, and asciminib has shown that it works by this myristoyl pocket mechanism of action and has the potential to be standard of care in these kind of patients. Next, please. So where are we right now as a third line? It has shown excellent efficacy and minimal side effects and improved toxicity. So minimal toxicity there. The T315I efficacy is established in the phase 1-2 trials already. But it is, of course, for the T315I, the asciminib is used at a higher dose. There are currently ongoing trials. There is a promising preclinical data, and we are awaiting other data for in the near future that will come out for second line and the front line. But right now, the medication is only and only approved as a third line. 2-line failures as intolerant, or 2-line failures at least as a resistant. So the current approval of asciminib is only as a third line. And for T315I, but at a higher dose. Next slide, please. So let's look at a few cases quickly. Do we have time, or is it? Okay, next slide, please. Next slide.
Next slide.
Okay. So this is a 34-year-old female. I saw this patient in 2012 and I put her on imatinib at that time. She developed severe immune hepatitis, which was clearly related to imatinib, and she responded to discontinuation and actually was seen by rheumatology and autoimmune disorders, and was clearly by the GI and hepatology, was clearly associated to imatinib. So I switched her to dasatinib. She tolerated initially very well and remains into a deep molecular response, but developed eventually severe headaches in 2017. All the workup, including the MRIs, the neurology consultations, and everything was done, but she was not able to tolerate dasatinib any further. So there was no choice. I switched her to nilotinib in 2018. And she was okay on nilotinib for 5 years almost, and then again started having severe headaches to the extent that she was admitted in the emergency room a few times, and even severe headaches on lower doses. Now, one needs to understand about these drugs, the second line generations, that you can actually keep them on lower dose if they have major molecular responses and they maintain their responses. You can actually lower the dose and some of the side effects can go. But in this patient, the headache was so severe that I had to stop the drugs. And nilotinib was stopped in 2023. Next slide, please. So resolution and avoidance of recurrence of headaches were the major things. Side effect profile of next therapy, duration, durability, and depth of response, progression-free survival, quality of life. So all these questions have to be kept in mind when you are going to switch as a third line therapy. Now, in this case, it would have been a fourth line. So let's next slide, please. So when you look at the headaches, that was the major concern. It is, although this by NC, I don't know why they forgot to mention, and the dasatinib is one of the major issues is a headache actually. And you look at the nilotinib and then bosutinib also, ponatinib is almost 43%, and asciminib is to some extent is lower. So the asciminib, I decided to use this drug after 3 TKIs intolerant and resist to move to asciminib. Next slide, please. So this was the choices available to me at that time. The bosutinib was available in our hospital on form by the pharmacy. Ponatinib is on the formulary. Asciminib available on the form A again. Other agents, I would not use it. She's young female. And stem cell transplant, I was reluctant unless she fails another 1 or 2 lines of therapy, then I could actually offer her stem cell transplant. Next slide, please. So this is it. So I started her. She had failed her. Her BCR-ABL was already higher when I stopped her the last drug, nilotinib. It was 2.2. Prior to starting the 4th line therapy, that was asciminib at a dose of 40 milligram BID. The 3 months response, she achieved a major molecular response within 3 months of starting the therapy. And I just saw her last week. There's no significant headaches, excellent tolerance, and she's compliant to the medications. She's happy. So this is out of the trial. This is not the trial patients. So this is the real world data. Next slide, please. Now, this is also another case of intolerance resistance to TKIs. This is a 47-year-old female in 2011, started on imatinib, achieved major molecular response, but became intolerant to it because of continuous lower abdominal pain and unable to tolerate persistent nausea and vomiting despite all supportive care, even decreasing the dose. So labeled as imatinib intolerant 2012, then 2012 dasatinib was started again, achieved major molecular response, but continued to have same symptoms as those of imatinib, unable to tolerate it. So labeled as 2013 as dasatinib intolerant. Next slide, please. 2013, she was started in nilotinib because these were the drugs that were available at the time. She achieved a deeper molecular response with it, even up to undetectable sometimes. Between 2000 and 2017, she was okay, but loss of MMR lately around 2017. No other TKI, there was no TKI mutation in this patient, and nothing else was available at the time, and even ponatinib was not available. But in 2019, she was labeled as nilotinib resistance, and no other TKIs available. Next slide, please. So the chances, what will be the next? Bosutinib would have been, was not, to me, was not available at that time. Ponatinib, I had to ask for on Form A. There was a clinical trial available, other than stem cell transplant. So I opted to go for a clinical trial because this is what was a new drug development at that time. So she entered in the very beginning of this assembled trial. So I put her on assembled trial. Can I go to the next one? So this is it. So she started with an BCR-able IS of 4.9. And there was no additional chromosomal abnormalities in chromosome analysis. The bone marrow was in chronic phase, nothing unusual. No able kinase domain mutation was detected. Next slide. So now look at the response. So in July 2019, I started her on 70-40 milligram BID. In 1 month, she achieved a status that was a complete cytogenetic response. In 2 months' time, in September, she was in major molecular response. In 3 months' time, she had already achieved a 4 log reduction. And by the end of 5th month or coming close to 6 months, she had achieved more than 4.5 log reduction already. So, and continued to have this deep molecular responses. In April 2020, she achieved a complete molecular response and undetectable BCR-able, and even now on a follow-up, while she is on asciminib, excuse me, please. She is currently in complete molecular response or undetectable minimal residual disease. So it's such a robust response, and she's 5 years now, and with an undetectable minimal residual disease with the minimal side effects. Actually, she does not have any reported side effects to me, and she's doing very well. Next slide, please. So the efficacy of asciminib established in more than 2 TKIs failure intolerance. In this case, patient was intolerant, and she responded to asciminib very well, maintained CMR undetectable at 4 years of follow-up. With the excellent safety profile, no side effects of abdominal discomfort, idiopathic bowel symptoms or nausea, vomiting, and better compliance, of course. Next slide, please. So future holds promise in chronic myeloid leukemia, even in these unmet conditions where you have no mutations that you can target, but there is intrinsic resistance or intolerance to these. It has shown superiority in all aspects of improving major molecular response, event-free survival, along with minimal or low toxicity compared to bosutinib, which itself also is an excellent drug. But asciminib has shown superiority not only in the response assessment, but in the safety profile also. So incorporation of asciminib as a third-line therapy is a safe and effective treatment option. It does improve your major molecular response rate and better event-free survival. Of course, it helps in avoiding transformation. It reduces in reducing the long-term toxicity and improved quality of life. And this improved quality of life has been shown by the patient-reported outcomes, actually. Next slide. So future holds promise. Utilization of TKIs with different mechanisms to complement the efficacy of treatment outcomes can be used. Incorporation of newer agents upfront, alone, or combined therapy. There are a lot of data is coming out. A lot of what was presented in ASH also. We just waiting for the updating of this data. But one has to understand that a single agent has shown not only safety but better tolerability. So until unless these combined medications shows, patients can go into undetectable within a very short time, and it translates into a better treatment-free remission. I think 2 agents combined together probably would not be the best choice until unless it translates into a better event-free, not only event-free, but a longer treatment-free remission and a higher number of treatment-free remission for the patients. Safety and efficacy treatment options in first-line therapy to achieve treatment goals in the presence of near normal life expectancy. And this is what the objective for all drugs is. Next line, please. Next slide. So just last, this is just what you call more of a statement rather than something. In the era of continuous development of new targeted therapies with seemingly excellent response and long-term progression-free survival, the approach to the patient with CML is holistic to provide the best outcome in survival and quality. And this is what I tell my patients. When I see them, I tell them that you have, for example, hypertension. You keep taking the medications. You don't question when I'm going to stop, when I'm going to do this, what will happen. If you have diabetes, you're taking medications, you're enjoying your life. For this time also, They're excellent medications which can keep you in remission for a longer period of time. So enjoy life and trust your physician. And the physician is the one that needs to hold the hand of the patient to take the patient to a proper journey, because the long-term survival is just like any other normal patient or any other person in the community. I think this is the last one. Can I have the next slide? So thank you very much. This is our King Faisal Hospital, and this tallest building is our King Abdullah Center for Cancer and Liver Disease, and our Cancer Center of Excellence is in this building. Thank you very much again and giving me the opportunity. I apologize for the one that I could not connect in the beginning because of the internet issues. Thank you very much. I'm available for any questions.
Thank you so much, Dr. Naim Chaudhry, for your good and excellent talk.
What's the question?
Any question?
The floor is open for questions, please.
Any question?
First question, please, Dr. Naim.
Yes, please.
Did you hear me, Dr. Naim?
I can hear you.
Okay.
I want to ask you about yes. What is your experience and opinion about using two tyrosine kinase inhibitors?
A very good question. There is a lot of data. People are using it only on trials. So number one, it should only be used on trials because there is no standard of combining of two TKIs. I have not done it because I don't have a trial. So out of the trial, I would not use it. There seems to be superior efficacy in getting an earlier response, but does it really translate into a better quality of life? Does it really translate into a better event-free survival? And more importantly, will you be able to get the patients off therapy quickly? That is still up in the air. The data seems to be promising, but right now, I would not use it out of the trial. And my experience is minimal. I have not used it as a combination.
Thank you.
Okay, my question, Dr. Naim. As you said, the asciminib is used as a third line, not
Yes, please.
first line or second line. But before using asciminib, did you advise to do mutational analysis for all patients?
Yes, the question is that it is approved only as a third line right now because we do not have mature data regarding the trials that are going on to bring it into a second line therapy. So it's only approved as a third line. That means 2 lines, intolerant or resistance. Yes, I do check for mutation analysis for any patient that failed the first line therapy. I don't check it at the time of diagnosis, but at the time of the first line therapy, I check for mutation analysis. At the time of second line therapy failure, I again check for the mutation analysis. For intolerant cases, I don't normally check it unless I see that the patient is trying to take the medication, but their BCR-ABL is very, very high. Not because of only intolerant, because some of these intolerant patients try to take the drug also. And so there should be some decrease in BCR-ABL, even if they are to some extent intolerant. But for all resistant cases, yes, mutation analysis should be done. Because if there is a T315I mutation, for example, then asciminib has to be, if your regulatory body has approved it, has to be used on a very high dose, which is 200 milligrams BID, which will obviously the cost will probably be 4 to 5 times. Or you can go to simply to a very superior drug, which is ponatinib for T315I.
Yes, from your experience, Dr. Naim, did you use asciminib in accelerated anaplastic crisis or just in the chronic phase?
No, only chronic phase. I've not used in the accelerated blast phase yet. We are thinking of opening up a trial in combination for blast crisis CML, but it has to be an in-house trial. I'm still working on it, whether it is feasible or not, but that would be a trial.
Okay, thank you. Dr. Marwan.
Thank you. In the era of TKIs, where does bone marrow transplant stand? Do you, at the moment, do you send patients for BMT?
No, the only patients that we are doing bone marrow transplant are the one that have transformed into a blast crisis, or they presented with CML blast crisis to our institution. We treat them, get them to a second chronic phase, and we take them to transplant because that is still the therapy of choice and indication for that. But otherwise, even if they fail 2 lines, they fail 3 lines, I still continue TKIs. Now that asciminib is available, I can use asciminib even before if I have to use ponatinib. So it's a safety efficacy is very, very important. Ponatinib has a lot of cardiovascular events that one has to be very careful about. So and this is a drug that is available as a safe and a very effective drug. So I don't take them to transplants unless they have exhausted all tyrosine kinase inhibitor. Even when I put patients on ponatinib and I don't take them to transplant earlier, but I keep telling them if they are unable to achieve a major molecular response or at least a CCR, I will then take them to transplant. Or if they start losing their major molecular response on ponatinib as a last resort, I take them to transplant.
Dr. Naeem, when we can stop tyrosine kinase inhibitors, if the patient is have many years need cyclophosphamide.
For the first generation imatinib, if they achieve an earlier molecular response at 3 months and 6 months, and at 1 year there are major molecular response and deeper molecular response at 1 year, or MMR 4.5 or undetectable in 2 years. I think for imatinib, they say 5 to 7 years of use. So both things are important. 2 things are important. They say the duration of treatment of TKI is also important, and the depth of response, maintenance of the depth of the response for at least 2 to 3 years is also important. So let's say imatinib, you have somebody on imatinib and they have achieved a deep molecular response at 2nd year, and you continue to use it for the next 4 or 5 years, and the last 2 or 3 years is in deep molecular response or undetectable, that's the time to stop it. For dasatinib and nilotinib, they say you may cut the duration of therapy instead of 5 to 7 years to maybe 4 to 6 years. But definitely, I would try to avoid anybody to stop the treatment before 4 years of use of TKIs, especially the second line. And the last 2 years or 2.5 to 3 years should be at least in the deep molecular or undetectable or complete molecular response.
Thank you. Thank you.
It's my pleasure.
Thank you, Dr. Naeem, and we will hope to see you personally in Jordan. Thank
you so much. Thank you for your invitation, and thank you for everyone.
Assalamu alaikum. Good afternoon, and good morning for our speaker from the United States. I am Dr. Ahmed Othman, and my colleague is Dr. Hadi Tahani, will chair this session, and we are moving to a different flavor. I'm really obliged and very pleased to introduce to a well-known figure in the missionary, Dr. Rami Komrokji. He is the vice chair of the Malignant Hematology Department at the Mofty Cancer Center, Mofty Cancer Center in Florida. He is a senior member of the Malignant Hematology and Experimental Therapeutics Program at the Moffitt Cancer Center and a professor of medicine and oncologic sciences at the College of Medicine at the University of South Florida. Dr. Komrokji is a well-known expert, and in fact, his expertise is highly appreciated across the world. He's very knowledgeable in biological neoplasm and myelofibrosis. In fact, his experiments and research have led to the accelerated approvals of certain drugs in myelodysplastic syndrome, such as lusaparticin and another drug, pacritinib, in myelofibrosis. Now, these two drugs have paved the way and opened a new era in the management of these two diseases. As we all know, myelodysplastic syndrome is a very tough subject. In fact, it's a tough subject for the clinicians, for the patients, and we are now ready to have Dr. Komrokji with us. Dr. Komrokji.
Assalamu alaikum. Thank you for the kind introduction. Shukran كثير. It's always a pleasure to be in Jordan, even virtually. I'm a proud graduate of Jordan University years ago. So I was asked to talk about myelodysplastic syndromes updates this year, and I'll try to provide some update on the classification, the risk stratification, and then talk mostly about the treatment and the evolving landscape. So, as well known to the audience, myelodysplastic syndrome are a group of neoplastic stem cell disease. They are characterized clinically by bone marrow failure, so patients present with cytopenias, a tendency to progress to acute myeloid leukemia. Not every patient will progress, 1 out of 3. Unfortunately, most patients will die from complications related to the cytopenias. It is a disease of older population. The average age is like 70. In most of the cases, we don't really know what causes MDS. Prior chemotherapy, exposure to benzene are known as risk factors. Nowadays, we know that the disease is genetic, and in 90% of our patients will be able, excuse me, to demonstrate an abnormality. By the traditional cytogenetic testing, 30% of the patients will have an abnormality. But with the introduction of next generation sequencing, we can identify abnormality in 80 to 90%. And those can be lumped into pathways. It turns out that MDS is mostly a splicing machinery and epigenetic deregulation mutation disease. And shown here are those abnormalities. Obviously, nowadays we talk about pre-MDS conditions where we can detect those abnormalities in patients before MDS. So there are two entities. One is called CHIP, clonal hematopoiesis of indeterminate potential. Those patients don't have abnormal blood counts. Those were originally done in cardiology studies. So if we sequence 100 person walking in the street with no blood abnormalities, 10 to 20% will have a somatic mutation in the blood, indicating clonal hematopoiesis. Those patients are at higher risk of developing therapy-related MDS, or MDS in general. If they get chemotherapy, they are at 6 to 12 folds higher risk of developing therapy-related MDS. But their number one mortality is accelerated atherosclerosis and cardiac mortality. And there are risk models now to estimate the risk of those patients developing frank MDS. And then there's CCUS, clonal cytopenia of unknown significance, where the blood counts are low, but the pathologist is not seeing enough dysplasia, which is the hallmark of MDS. And that's another stage before. Many programs in the United States are establishing clinics to look into this, There are preventive studies, cardio-oncology programs. I think in addition to the mentioned factors such as developing MDS or coronary artery disease, we do see also donor-related chip after transplant. As I mentioned, we counsel our patients with solid tumors if they have those mutations about the risk of therapy-related AML or MDS. And in some cases, if the marginal benefit of the chemotherapy for the solid tumor is small and the risk of developing therapy-related MDS or AML higher, we try to find alternatives for chemotherapy, especially in the adjuvant setting. Now, also MDS is a disease of inflammation, so there is clear evidence now that the MDS has an interplay between those somatic mutations and the inflammation, and it's almost like the chicken and the egg, which started first, the mutations that promote this inflammatory milieu or the inflammation that leads to stem cell instability is not clear, but both of them are important. Clinically, obviously, patients that have connective tissue disease are at higher risk of developing MDS. Patients with MDS may have connective tissue or like inflammatory manifestations. There is a lot of literature currently describing a syndrome called VIXUS, which is an acquired mutation in a gene, typically in males, that leads to a spectrum of inflammatory manifestations. And targeting the inflammation is an area of active research where there is a lot of clinical trials investigating drugs targeting the inflammation because it's thought to contribute to the myelosuppression. Now, as you know, the MDS classification had evolved over time. For many years, we used the FAB. Then there was the WHO classification with different versions or revisions. Last year, there was a split. As you know, with anything political, there was a little bit political aspect for this. So there are two groups, the WHO and ICC. That created a little bit dilemma in the field from pathology point, from how do we treat those patients. But in reality, those classifications have a lot of similarity. I think the point where we are moving with the classification for MDS, we know now that MDS is almost like a generic term. It's almost like saying somebody have leukemia. So there are unique subtypes that have a biology that is unique to them. And clearly the two classifications recognize that there is molecularly defined MDS. So we have this entity MDS SF3B1, and definitions are shown here, deletion 5q, which we have known for many years. And then there is the TP53 MDS that's unfortunately always associated with the worst outcome. The two systems vary a little bit in the definitions, but the idea that now the first step when we define MDS, we look at a biological or molecular classification before a morphological one. In SF3B1 deletion 5q, the myeloblasts have to be less than 5%. And in P53, we look whether it is biallelic, which means the two copies of the P53 gene were affected. Obviously, in areas where there is no access to molecular data, there are some surrogate tests that can help. SF3B1, 80% of those patients will have ring sideroblasts on the bone marrow. A good hematopathologist will be able to show or see the changes with deletion 5q. And for P53, there are some immunohistochemistry stains that are published and can be done as a surrogate marker for the P53 mutation. Now, if the patients cannot be defined molecularly, then we still define them morphologically. And again, there are some slight differences here, but the idea is still the same. If the blasts are less than 5%, that's MDS with low blasts. If the blasts are more than 5%, that's excess blast. The WHO introduced a hypoplastic MDS group and also a MDS with fibrosis. And the ICC introduced this entity of transition, MDS/AML, if the blasts are 10 to 19%. For those of you who have been doing this for a while, you remember we used to classify AML if the blast more than 30%. Then they lowered the threshold to say it's 20% because patients between 20 to 30% have the same outcome. And now the ICC is coming and saying that 10 to 19% is considered MDS AML. And it's not clear really where the cutoff is arbitrary. In my opinion, if the myeloblasts are more than 5%, that's different biology. this classification helps us a little bit sometimes, at least in the United States. Now we are able to get some of the medications approved for AML, used for MDS, but it does create some anxiety for the patients. And it does not mean that every patient that have a 10% or 11% myeloblasts should be treated as AML. Those are, decisions that should be individualized. Molecular profile can play a role. There are some abnormalities that are more AML defining. And that's another thing that the WHO introduces and the ICC, that there are certain more cytogenetics defining for MDS or AML. So for AML, historically, the core binding like translocation 821 and Virgin 16 were AML defining. Now they added things like Virgin 3. The WHO, regardless of the blast, will consider those AML. The ICC wants the myeloblast still to be more than 10%. So, but the idea is the same. So the first thing, we look at the molecular entities. Can we define the patient into a molecular entity? If not, we still follow the morphology classification. We've been trying to drive this into a harmonization, and we've presented several presentations. This last one, we tried to look at the classification merely based on genetic data and see if patients can cluster into certain genetic groups. And indeed, as you can see here, like there are at least 6 groups where patients can cluster in. And at the end, I think this is what we propose is, as I mentioned, we ask, are the patients biallelic TP53? Are the patients deletion 5q, SF3B1? If not, then we define them morphologically. But in my opinion, I think we could think of it in different way. This is my own classification that's very simple. We could think of a chronic low-grade MDS, those with SF3B1, which is mostly a ring sideroblast MDS, deletion 5q, and those have low blasts. There is an accelerated phase of MDS once the myeloblasts are more than 5%, if they have a biallelic TP53 or MDS with fibrosis. And then there is AML coming from MDS, and whether the cutoff is going to be 20% or plus minus, it's not clear. But those patients had either prior history of MDS or they have MDS defining cytogenetic or genetic abnormalities. I think probably what's more important is the risk stratification, because we tailor our treatment based on this. And in reality, it's deciding who are we going to take to transplant versus treat them stepwise. And there have been several models. I think the most recent, obviously, is this IPSSM. So it builds on the International Prognostic Scoring System, which is a simple scoring system in a way that looks at the blasts, blood counts, and cytogenetics. But this incorporates molecular data. And you can see here that there are like data from 17 genes as main effect and another 15 genes as a residual effect. You plug this in. This is a calculator available online, and it will give you a risk. I think even if the genetic data are missing, because the model accounts for the blast blood counts as continuous variables, it's actually a little bit more accurate than the IPSSR or IPSS that we historically used. And you can see here that patients can be divided into 6 groups, and risk is for an average patient. So you have 3 groups that we consider higher risk and 3 groups that we consider lower risk. And the model clearly, refines the prognostic outcome. If a patient is a very high risk, those patients unfortunately have less than a year survival. While if a patient is a very low risk, those patients will have almost 10-year survival. And when we use this model, almost half of the patients are re-stratified, and around 7% of the patients, their staging will move by 2 stages. So the question, what to do with that? Is this something we should incorporate in practice? And the answer is probably yes, at least from a transplant point. This is some work also we presented in collaboration with the Italian group at ASH last year. We looked at a artificial intelligence analysis actually about the best timing of transplant based on the IPSSM. And in 45% of the cases, you will change your timing of the transplant. 13% you'll actually wait, and 32% you'll go earlier. So as you know, historically, we decided on transplant timing based on Markovian decision analysis models. If patients were lower risk MDS, the maximum gain in survival is to wait. If patients were higher risk, the maximum gain of survival to go to transplant. So if I see a patient that now I upstage by IPSSM by 2 stages, or they were intermediate and they are looking higher risk, particularly if the patient is a little bit younger, I definitely will consider earlier transplant. If the patient is not candidate for transplant and we upstage those patients, it doesn't mean automatically that we have to treat those patients with hypomethylating agents if their counts were adequate, because hypomethylating agents improve survival by improving the blood counts. So if somebody's blood counts are reasonable, they are not transfusion dependent, they are not candidate to transplant, even if I upstage them, I will not treat them. So I use the IPSSM in terms of prognostic tool to inform the patients about their outcome and as a tool to decide if on the timing of transplant. Now, if we look at if we label the patients as lower risk and we look at the natural history of the lower risk MDS, I think, lower risk MDS, particularly in other countries and in Jordan, from my experience, is a little bit under-recognized. Many of those patients are anemic. They get blood transfusions with their primary care physicians and may not see hematologists. And there is this notion that those patients will do relatively well. But in reality, if patients are transfusion dependent, lower risk MDS, their survival is only 3 years. And we try to look at what happens to those patients with lower risk. This paper is published now. So most of the patients, as you can see here, will stay lower risk. There is a group that will go to higher risk and unfortunately die in higher risk. There is a group that will go to higher risk than AML. And there is around 10% of the patients that will go from a lower risk to a higher risk disease. And you can predict those patients based on some clinical variables, but mostly mutations. So those patients that have IDH1, IDH2, NPM1 are the ones likely to progress immediately. Now, even in the patients that we labeled that are lower risk and gonna stay lower risk MDS, more than half of those patients die directly from complications of the cytopenias, blood transfusions, or interplay between of the cytopenia and comorbidities such as coronary artery disease. So again, the notion that we label somebody lower risk MDS, it doesn't mean that this is a disease that's not going to impact patients' outcome, particularly when patients are transfusion dependent. This is data from the Italian group years ago, looking at outcomes for MDS patients lower risk based on transfusion dependence. And on the left here, you can see that the outcome, is dependent on the blood transfusion. So if patients are needing 4 units or more in a month, you can see that the median survival of those patients is almost less than a year. And the question always so if you treat those patients and their response to treatment, whether you are giving them erythropoietin, azacitidine, lenalidomide, do they do better? All data are retrospective, looking at a responder versus non-responder analysis. Those are data from lenalidomide for both deletion 5q and non-deletion 5q, but clearly responders do better than non-responders. This is data from luspatercept, showing again, if patients were transfusion dependent, responded, their survival as better. We tried to look at this also in a different way. We tried to look at, the responses to first and second line. We took all lower risk MDS patients in our data set and looked at those patients that got erythroid stimulating agents as first line and then other treatment options as second line. So first, half of the patients will not get anything beyond erythropoietin, unfortunately. Responses to erythropoietin in our data set were, roughly around 40%. Any second line we applied after erythropoietin, the responses were 27%. And beyond second line, the responses were very low. But then we looked at the survival based on the response as shown in table 2 here. So a yes means response to first line, yes response to second line, and so forth. The best outcomes are really for patients that respond either to the first or second line treatment. So I think obviously it's not acceptable to have a lower risk MDS patients just to be getting supportive care with blood transfusions. And in many instances, we actually start the treatment earlier. For many years, obviously, the standard of care had been erythroid stimulating agents, which in RS negative probably remain the standard of care. In our practice, if somebody's hemoglobin is less than 9, particularly if they are starting to be symptomatic, and their EPO level is low, we start erythroid stimulating agents. We don't even wait for those patients to become transfusion dependent. Whereas this is changing now in the United States. For the first time, we have a first-line therapy with luspatercept upfront, changing the paradigm of having erythroid stimulating agents as the first line in all comers. So this is the COMMAND study. It used luspatercept. As you know, luspatercept is a fusion trap protein that neutralizes TGF-beta ligands that act on terminal erythroid differentiation. So erythroid stimulating agents work early on erythroid differentiation. Luspatercept works later on. It's an injection given once every 3 weeks. We think of it as erythroid maturating agent. We conducted studies in the past in patients with ring sideroblasts, particularly where activity was noted, and that led to the approval after ESA failure. So in this study, we tried to look at comparing this head-to-head to ESA. So we took patients that were lower risk MDS, transfusion dependent, randomized between luspatercept and erythropoietin, and the primary endpoint was transfusion independence and hemoglobin increase. But this study was enriched with patients with ring sideroblasts. The study actually did show doubling of the responses, 60% versus 30% responses, more durable responses. But in reality, when you look as shown here on the right side, the magnitude of benefit was really mostly in RS positive patients. The responses were more durable, but again, when you look at the durability, it's more in RS positive. The FDA actually approved luspatercept now as a first line in all comers, but in our practice, based on this, I don't think the subset with ring sideroblast negative were enough to make that generalization, particularly that the cost of this therapy is almost $20,000 in the United States per injection versus erythroid stimulating agents that are available as biosimilar. In patients that are ring sideroblast positive, it doubles the response, doubles the duration. So I think it's very reasonable. In RS negative, I don't think it's reasonable, mostly because of cost related issues. The treatment in general is well tolerated. There is some fatigue observed early on, but it's really regarded as a growth factor. We've been trying to look at combinations since erythroid stimulating agents work on early step. Can we combine them? And this is a small series we published that shows basically, yes, you can combine them. If patients had some response to luspatercept and they were losing the response and their EPO level is low and we added ESA, we saw responses in almost 30% of the patients. There is another compound very similar from a company called Keras. It's called KER050. It has a little bit different profile. It's going into phase 3 in this year, but it's shown activity in areas where luspatercept did not perform well, such if patients were very highly transfusion dependent or in patients with RS negative. So this is going to be going in phase 3. And it could be an opportunity to join to get access to those drugs in a phase 3. The other drug that we've been developing for lower risk MDS is imetelstat. This is a telomerase inhibitor that had been tested in phase 1 and 2, showed activity. And this is the phase 3 data that looked also at lower risk MDS patients that were highly transfusion dependent. So those patients at least were needing 2 units of blood per month. Randomize the patients between imetelstat, which is an infusion given once a month, versus placebo. And the study met the primary endpoint. 40% of the patients became transfusion independent. The median duration almost a year. Hemoglobin goes up by 3.6 grams. So this is next to like lenalidomide, basically, in terms of response. And we see responses both in RS positive, RS negative, and we see responses regardless of the transfusion burden. And the main issue with it can cause myelosuppression. So it's like azacitidine or decitabine, that you'll see neutropenia, thrombocytopenia, that you may have to delay the second or third round and decrease the dose of the treatment. But the incidence or the rate of febrile neutropenia was 1%. What's exciting a little bit about imetelstat is we also see some potential of disease modification, where we see reduction in, we see cytogenetic responses and reduction in some of the mutations allele burden. Now, in the United States, at least, in Europe and Canada, hypomethylating agents, azacitidine or decitabine, are not approved for lower risk, but in the USA they are, and when we use them, particularly when patients have concomitant thrombocytopenia or neutropenia that will not allow us to use lenalidomide or they need treatment. And along with our colleagues from MD Anderson, we've been trying to look at this shorter duration of using 3 days. So if we use hypomethylating agents in lower risk, I usually try to use them as last step, or if the patients have severe thrombocytopenia or neutropenia. But if we use them as 3 days. And there are also obviously oral hypomethylating agents approved, decitabine oral, that we use and we can use in lower risk MDS. The oral azacitidine available that is approved for maintenance in AML in the United States is not equivalent to azacitidine sub-Q or IV, so we don't use that in MDS. Last month, I think, or so, the FDA approved IDH1 inhibitor, ivosidenib, in relapsed MDS, and it really did not give it a label whether it's higher risk or lower risk. So patients with IDH1 mutation can get this treatment as well. Particularly, I think, in HMA failure, which I'll come back to address a little bit, is very helpful treatment. So this is how I manage lower risk MDS currently. The first question I ask, does the patient need a treatment? If they have adequate counts and they are asymptomatic, there is no evidence really of earlier treatment. Then we ask, what are we treating? Very rarely we will be treating isolated neutropenia. Most of the time we don't. We have patients with ANC of 200 for many years that we are observing. But if the patients get recurrent infections, neutropenic patients tend to be enriched with IDH1 mutation or 2. So if they have that, we go after IDH mutation. If not, low-dose hypomethylating agents, or if they are young patients, we use immunosuppressive therapy, similar to aplastic anemia. They don't have to have a hypocellular bone marrow. If we are treating isolated thrombocytopenia and no high-risk features for the disease, TPO stimulants, romiplastim, and Trombobag is a reasonable option. In majority of the patients, what we are treating is anemia. If their hemoglobin is less than 9, then as I mentioned, we start treatment. So we ask, do the patients have deletion 5q? And if the answer is yes, we do lenalidomide. The Spanish group had pioneered this study to start lenalidomide earlier on, before patients are transfusion dependent, do only 5 milligrams fixed duration for 2 years. So that's something we are moving into, to do earlier treatment in deletion 5q. If they have ring sideroblast, luspatercept is first line. If they don't have ring sideroblast, then erythroid stimulating agents are our first line. Moving to higher risk, as I mentioned, we use now the IPSSM to assess who's going to go to transplant. In reality, allogeneic stem cell transplant remains our only curative option for those patients, and we are doing more and more transplants. At our center, we offer transplant even up to age of 80 for those patients if their performance status is good and they have no major comorbidities. And in patients that are higher risk, we go to transplant earlier. A lot of discussion is about treatment before transplant. What should we do? What dictates the outcome after transplant are the percentage of the myeloblast going to transplant, cytogenetics, and molecular. And there is really no conclusive data on what to do. Most of the transplanters, at least in our center, want the myeloblast to be below 10% before proceeding to transplant. My bias, if the blast percentage is lower, or if we can get the patients to below 5%, they will do better. A very challenging entity are those TP53, especially the biallelic. Do we take them to transplant or not? If patients go with detectable P53 to transplant, they have almost 80% chance of recurrence, and the cure rates are only 10 to 20%. So our approach is to try to start hypomethylating agents in all patients, particularly in the P53, try to clear the mutation and go to transplant. And with that, you can see on the left, that the cure rates, are way better. While if we were not able to clear the P53, there was no difference in the outcome. And we actually come and do maintenance for those patients. So in general, if patients are higher risk, we are going to transplant. We start hypomethylating agents. I'll touch base a little bit now. We incorporate sometimes venetoclax, and we go to transplant. And in some high-risk patients, we incorporate maintenance for those patients. In majority of the patients, they will not be going to transplant, so hypomethylating agents remain our standard of care. The original studies that showed survival advantage with azacitidine showed a 24-month survival. Nobody had ever been able to demonstrate the same benefit. What we tell patients, around 20% will get a complete remission with azacitidine or decitabine. The average survival is around 20 months. Typically, if we are doing azacitidine alone in the higher risk, we do 7 days. We do 4 to 6 rounds and assess treatment. And if the patients are responding, we continue the treatment indefinitely. In older patients, if they are not going to transplant and you're doing azacitidine after the 3rd, 4th round, they are responding, you can argue you don't even need to repeat a bone marrow. As I mentioned, in the United States now we have oral decitabine that's 100% bioequivalent and can be used interchangeable to decitabine in those patients. It's been really challenging. We call higher risk MDS the boulevard of broken dreams, because every study we tried to do adding something to azacitidine so far had not shown improvement in the outcome. We've run numerous studies, magrolimab, APR246, pavindostat. All of those studies unfortunately did not show superiority to azacitidine alone. There are only 2 ongoing studies, and now a study called the Verona that's randomizing patients between azacitidine venetoclax, and a study looking at a drug called tamiprotein that is a RAR alpha agonist. So the patients have to have the RAR alpha overexpression, and randomizing patients between AZA and azacitidine, and that study is available internationally, so there could be opportunities to join. Now, obviously, venetoclax is approved for AML, so a lot of people are borrowing the treatment. This is the phase 1B data. You are using a venetoclax in MDS, then it should be only 2 weeks, not 4 weeks like MDS. It looks very promising, doubling the complete responses and promising survival data, but we are waiting for the final results. This is our data looking at venetoclax. So we do incorporate venetoclax for 2 weeks in patients that are going to transplant, in patients that have a very high percentage of blast approaching like AML, and in patients with ASXL1 mutation. So you can see in our experience, those are small numbers, but we see doubling of the complete responses. ASXL1 usually doesn't respond very well to hypomethylating agent alone. So we see doubling of the or tripling of the responses. And when we looked at AZA-VEN transplant, 2-year survival is 90% compared to 50% historical. So those are the situations where I use venetoclax in patients that if their myeloblasts are 19%, that's almost AML. So we use it in patients with ASXL1 or if they're going to transplant. In P53, particularly if they're not going to transplant, there is really no benefit of venetoclax even in AML. Our colleagues from MD Anderson has been pioneering this total oral therapy. So they do oral decitabine, venetoclax, and very similar results to what I showed you. And the group from Albert Einstein in New York had been looking at this metronomic. So rather than doing the 5 days of decitabine or azacitidine, they do a very low dose of decitabine. It's per kilogram 0.1. So this is probably 20% of the dose of decitabine or 10%, but they do it once a week, and they do venetoclax also once a week. So it's a very low dose, but continuous exposure. They do the first phase for 12 weeks, assess, and then continue. And they've been really showing very promising data, almost 50% responses, more tolerable. So in frail, older patients, when there are patients we don't think they will tolerate treatment, we do this, what we call the metronomic dosing of decitabine venetoclax. There is some data, or some people believe that this works better in P53, so they do this also in P53. As I mentioned, tamibarotene is the only other drug in phase 3 that is being tested in patients that have RAR alpha overexpression. It has shown also some promising activity in AML. HMA failure is challenging area. If patients have HMA failure, their survival is 4 to 6 months. So obviously, if we can take those patients to transplant, that's the best outcome. I think the message is reevaluate those patients. If you have access to molecular data, check those tests, because in 30% of the patients, you'll identify at least a target to go after with treatment. There are some studies, including ours, where you add back venetoclax for patients. In our place, if patients were on azacitidine, progressed, there is no target, we shift from azacitidine to decitabine and add venetoclax. And we've reported that maybe around 13% CRs and a little bit higher marrow CRs, so we can take those patients to transplant. But I think where we really can make an impact, if patients have detectable mutation, the ivosidenib was approved by the FDA for HMA failure. The median survival with single oral therapy is approaching 3 years. So if you have an IDH1 or IDH2 mutation, those are very powerful, easy to do medications if there is access to those medications, and they've been looked at in separate or different settings. So this is how I treat higher risk MDS. The first question I ask, are they candidates for transplant? And if the answer is yes, I think in most of those patients we'll go for HMA ven, almost like an induction for transplant. The available AZA, decitabine or oral decitabine are acceptable. Venetoclax only 14 days in MDS. You repeat a bone marrow at the end of the first round, assess the response. Many times the bone marrow is hypocellular and no blast, so we wait the recovery, and we actually cut down the venetoclax dosing in the subsequent cycles to 7 days or less. And then we take patients to transplant. We do maintenance in selected patients with higher risk, so we do hypomethylating agents after transplant, P53, 11q23, and inversion 3. If patients are not going to transplant, if they have P53, we only do single agent hypomethylating agents. If they have no P53, hypomethylating agents in SXL1, or if the blast percentage is very high, then we add venetoclax. So in summary, I think the modern classification of MDS really identifies those genetically defined disease entities. The line between MDS and AML remains blurry, and we should individualize the treatment for those patients. IPSSM is definitely a better tool, even if you don't have access to molecular data. You can use the IPSSM on timing of transplant decision. Luspatercept is new standard of care, replacing erythropoietin in lower risk MDS, but in my opinion, only in ring sideroblast positive patients. Imetelstat, hopefully, if approved by the FDA in this year, it will be second line therapy for patients, particularly with high transfusion burden. We are thinking of earlier use of lenalidomide, fixed duration, lower dose in deletion 5q MDS. Allogeneic transplant is still the only cure, even for lower risk MDS patients if they've gone through 1 or 2 lines of therapy. If we have access to transplant, that's not unreasonable to consider in younger patients. Hypomethylating agents are still the standard of care, and we could consider adding venetoclax in selected cases, as I mentioned. With that, I will stop, and I'm very happy to take any questions. Again, thank you for the invitation, and hope to be in Jordan soon in person. Thank you very much.
Thank you, Dr. Rahman, for this comprehensive and excellent presentation. And I think we learn more about especially for me, because I am a hematologist and part-time hematologist. We have only enough time for 2 questions or the last time. Any questions?
Thank you, Dr. Rahman. Back to the classification of the MDS. Now, it's strange that in the same year, 2022, we had 2 classifications. One, as you mentioned, elegantly, the WHO, and the second is the ICC. If you go back to the ICC, they ignored the morphology, and particularly the cellularity and fibrosis in their classification. And I think the morphology, and they concentrated, of course, on the molecular and as you know, the morphology, the cellularity, the fibrosis are important in the stratification and classification, and probably in the prognosis of the MDS. So if you are kind enough to comment on that. And the second thing is regarding classification as well. As we know, the MDS is a tough subject, and having this division between these two bodies will add to the confusion and will make the, designing and comparing the trials difficult. So, what do you think?
Yes, I think those are very well taken points. So the ICC does have still some morphology classification if the molecular is not there. But as you mentioned, they really do not include hypoplastic MDS and MDS fibrosis. I was actually part of the WHO that developed those, and we introduced those from our database. So clearly, hypoplastic MDS, if the blasts are not increased, should be thought of as separate entity because those patients may benefit from aplastic anemia treatment, ATG cyclosporin, and that's why we kind of emphasize that we should have this as an entity by itself. In general, if the blasts are not increased, they have favorable outcome. And you're absolutely right, fibrosis in MDS is very important. So MDS with fibrosis is an entity that have worse outcome. The WHO even introduced MDS with fibrosis if the blasts are more than 5%. In our data, even if the blasts are not more than 5% and you have a grade 2 or 3 fibrosis, those patients don't do well. That's why when I presented my own classification, that's kind of Rami classification, when we have MDS fibrosis, I do think of it as an accelerated phase. So your point is well taken. And then the confusion created is absolutely, a topic, and we are trying to come with data-driven, information to both the WHO and ICC, say unify those. I think what you also mentioned is very important because now which trials do you put those patients on, AML or MDS studies? And then which eligibility criteria, what blast cutoff? And then even more like the response criteria for AML and MDS on trials are different. So which response criteria you use? I think, obviously, as I mentioned, in my opinion, I think there is MDS less than 5% blast. That's almost like a chronic phase CML. Then there is accelerated MDS once the blast starts to increase, or if we have fibrosis. And there is a blast phase of MDS. And that's how I think of the disease continuum. The new classification, the only advantage I can see is, at least in the USA, like where we don't have, for example, approval for FLT3 inhibitors or IDH inhibitors in MDS, if the blasts now are 10%, we say, oh, this is AML/MDS, and we can use some of the treatments from AML. The other thing that sometimes in younger patients, let's say if you have 18 or 17% blast, you are thinking of transplant, maybe we can consider intensive chemotherapy and take those patients to transplant. But the message, as you mentioned exactly, I don't think we should treat everybody with 10% or more blast as AML. It's very confusing.
Thank you, Dr. Rami, for your excellent, elegant, and informative talk. Thank you, and we hope to see you in Jordan very soon. Thank you very much.
Inshallah, Allah khaliku. Thank you very much. Thank you. Assalamu alaikum.
Good afternoon. I'm going to present our next speaker, Dr. Teresa Macarola. She completed her specialist training in medical oncology, and she has appointments in Barcelona. Dr. Macarola is currently a physician in the medical oncology department at the Valdi Hebron University Hospital in Barcelona, Spain. She is also the head of the GI Cancer Program unit since April 2017. She is working with the GI tumors team. She is involved in translational research and pharmacodynamic phase 1 studies with molecular targets, therapies, and related translational research, which with a special focus on EGFR inhibitors. She is also involved in phase 2 and 3 studies with new chemotherapeutic agents in GI tumors with special interest in hematobiliary tumors. Dr. Macarola is the author of numerous publications, many focusing on hematobiliary tumors and new drugs. She has authored communications at different conferences. She actively participates in the development of national and international clinical investigations, especially in relation to drugs directed against molecular targets, as well as clinical investigations for new chemotherapy agents. She is also an advocate reviewer for various oncology journals. In addition, Dr. Macarola is an active member of the Spanish Society of Medical Oncology, ISMO, and ASCO Oncology. Please join me to welcome Dr. Teresa Macarola, and the stage is yours, Dr.
So thank you so much for the presentation, for this kind introduction. And I would like to thank, first of all, for the invitation to be here today. It's a great pleasure. And now I will share my screen. I will try to share. Here we have the presentation. You can see the presentation. Now you can see? Perfect. So today I am here to talk about immunotherapy in biliary tract cancer and why immunotherapy is the new treatment option for this disease. And also we will review briefly the context of new treatment options that we have in biliary tract cancer. Here you can see my disclosures. So first of all, a brief introduction about biliary tract cancer. So biliary tract cancer is a rare disease. It's not so common in the majority of the world, with an incidence between 1 and 2 cases per 100,000 inhabitants. However, and interestingly, it's really an endemic disease in some areas of the world. For example, cholangiocarcinoma is endemic in Thailand, and in Thailand, the etiology of this disease is a fluke, an infection by a fluke. And also we have, for example, in China, in which also it's endemic, and the etiology is an hepatitis B infection. And then we know that in these countries in which the etiology is different than in the rest of the world, the biology of those tumors is completely different than our tumors. Also, if you see the gallbladder tumor, it's a rare disease. It's less frequent than cholangiocarcinoma, between 1.5 cases per 100,000 inhabitants. And again, there's some zones in the world, for example, Latin America, in Chile, in Argentina, in which it's really a very frequent disease, and the etiology are the stones. And also we have a high incidence in east of Europe and South Asia. So interesting to see how the incidence is really high in some areas and the etiology is different. Also, when you see this slide, you can see which will be the tendency in the next years, and you can see here that we expected an increase in the incidence, but also an increase in the mortality in this disease. For this reason, hepatobiliary tumors will be the second cause of, the third cause of cancer-related death in 2040. So that's something that have to worry us. And when we talk about biliary tract cancer, we talk about an heterogeneous group of patients. So that includes gallbladder, includes ampullary cancers, extrahepatic cholangiocarcinoma, periheliar cholangiocarcinoma, and intrahepatic cholangiocarcinoma. Those tumors are completely different, so that's sometimes complex when you put together these different tumors in the same trial. For example, they presented different etiology, different prognosis, and the most important thing, different biology, and that's the most crucial part. So how we treat biliary tract cancer? First of all, what we have to decide, and ideally we have to decide it in a multidisciplinary tumor board if it's a patient presented a resectable disease or not. If the tumor is resectable, we have to resect the tumor, and then we have to give to the patient, if it's feasible, capecitabine as an adjuvant treatment as per the BILCAP trial. Then if the patient is not resectable, first of all, we have to order to do an NGS analysis, and we don't have to wait the results. We have to start immediately the first line treatment with gemcitabine cisplatin, and in those countries in which immunotherapy is approved, to add immunotherapy to this first line. Then what happened in second line? Patients that presented targetable alterations, as we will see later, have to be treated with target therapies, but those patients without targetable alterations have to be treated with 5-FU-based chemotherapy. So let's start with chemotherapy, which data that we have of chemotherapy in first-line biliary tract cancer patients. First of all, this trial, the ABC02 trial, established in 2010 the standard that we have still today to treat those patients in first-line with gemcitabine and cisplatin. This combination demonstrated a superior overall survival compared with gemcitabine alone, with a median overall survival of 11.7 months. When you see which are the patients or the tumors, the locations that benefit more from cisplatin and gemcitabine, as you can see here, all of them benefit from this double combination. So then we have different trials that try to demonstrate the superiority of a triple combination compared with this double combination. This is an example of the SWOG 1815 trial, in which patients in first-line biliary tract cancer were randomized to be treated 2-to-1 to gemcitabine cisplatin plus nab-paclitaxel or gemcitabine and cisplatin. The primary endpoint was overall survival, and as you can see this slide, the trial was completely negative, unexpectedly, with a hazard ratio of 0.93. So there's no benefit to treat our patients with this triple combination compared with gemcitabine and cisplatin. However, in a subgroup analysis, they demonstrated that when you see the effectivity of this triple combination in the different locations, the gallbladder are the tumor that benefit more from this triple combination, and when we see for the stage of the disease, the localized disease benefit more from the triple combination than the metastatic disease. But it was years ago in 2021 when it was published this French study that demonstrated that the triple combination FOLFIRINOX didn't add a benefit compared with gemcitabine and nab-paclitaxel. So we have the second trial that demonstrated that the triple combination was not better than double combination with cisplatin and gemcitabine. So for all these reasons, today the standard of care of chemotherapy in first line is still gemcitabine and cisplatin. Also, we had this drug, NUC1031, that it's a drug that don't need the enzymes to enter to the cells, so easily it can be activated into the cells than gemcitabine. So it's similar to gemcitabine, but easily activated. In a phase 1 clinical trial that combined this drug with cisplatin in biliary tract cancer patients in first line, demonstrated a response rate of 44%. So with this promising activity, they designed a phase 3 trial in order to compare the classical gemcitabine and cisplatin with this drug and cisplatin. And unfortunately, it was a completely negative again trial, demonstrating that cisplatin and gemcitabine was better than this new and in theory better combination. Let's now to move to immunotherapy, that in combination with chemotherapy is the new standard treatment in those countries in which immunotherapy is approved. So when we think and we review the biology of biliary tract cancer patients, we know that this tumor presented a high desmoplastic area surrounding the tumor cells, and also we know that we have a lot of cells in this stroma that can produce an immunosuppressive microenvironment. So historically, we thought that these biliary tract cancer patients are cold tumors, and in fact, here you have this classification, that is the STEAM classification, that take into consideration the tumor microenvironment in intrahepatic cholangiocarcinoma. And as you can see here, they divided the intrahepatic cholangiocarcinoma in 5 different subtypes. 35% of the intrahepatic cholangiocarcinoma, they considered to have an inflammatory microenvironment, and 65% without a microenvironment, inflamed microenvironment. And also when we try to test the immunotherapy in biliary tract cancer, but in monotherapy, as you can see here in different clinical trials, the activity was really modest with a response rate that was between 3 and 20%, but really modest. We have here one example of this trial that it was a phase 2 that included 46 patients treated with nivolumab in a refractory setting, biliary tract cancer patient. As you can see here, the central review response rate was around 10%, so really modest activity. What we know in the past, it was from this Keynote 158 study, is that patients with biliary tract cancer patient and MSI tumors presented a high response rate when were treated with pembrolizumab with a response rate of 40%, a duration of response of more than 2 years. That's incredible. So that's an interesting treatment, but for those patients with MSI. And then it was in this clinical trial, phase 2 clinical trial that was conducted in Korea, in which we started to see the synergistic effect between the monotherapy and chemotherapy. We know that monotherapy itself, it was not so active, but when we put together with chemotherapy, you will see that for the first time, we see really interesting results. In this trial, they included 128 patients with first-line biliary tract cancer patients, and those patients were treated with one chemotherapy, and in the second cycle, chemotherapy plus durva plus tremelimumab, gemcitabine cisplatin and durvalumab, or gemcitabine cisplatin plus durva plus tremelimumab. And as you can see here, you have the primary results of the trial with the primary endpoint of response rate. You can see the global of all the patients included in the trial presented a response rate in first line of 61%, with 5% of these patients presented a complete response. When you see in the different treatment arms, chemotherapy plus durva plus treme presented a response rate of 68%, that's incredible, with complete response of 2%. And when you see the patients treated with chemo plus durva, you have a complete response, radiological complete response in 6% of the patients and 66% of the patients with partial response. So indeed, in that trial, it was demonstrated the synergistic effect, how chemotherapy changed the tumor microenvironment and allowed this immunotherapy to be more active than in monotherapy. So based on these results, it was designed this clinical trial, the TOPAZ-1 trial, that it was a randomized phase 3 international clinical trial that treat or include patients with advanced biliary tract cancer patients that were randomized to be treated with durvalumab plus gemcitabine and cisplatin, or placebo, gemcitabine and cisplatin. Patients were treated only with 8 cycles of chemotherapy, and then they stopped chemotherapy and continued with durvalumab every 4 weeks in monotherapy or placebo. So this is a very convenient schedule for the patients. You can imagine that you explain to the patient, you will be treated with chemotherapy and immunotherapy only for 6 months, and then you will come to the hospital once per month to receive the immunotherapy. And patients really love this plan. So the primary endpoint of this trial was overall survival. The secondary endpoint was progression-free survival, overall response rate, the duration of response, efficacy by PD-L1 status, and safety. And this is a positive trial. For the first time after the ABC-02 trial, we have the first positive clinical trial. We have to wait 12 years to have these positive results with a hazard ratio of 0.80. And as you can see here, the overall survival curve is very typical from the immunotherapy trials. At the beginning, the curves are completely together, and then from the 6th month, you can see how the curves are separated, and every time during the evolution of the curves are more and more and more separated. You can see this tail of the curves in which patients really benefit from immunotherapy. When you compare the overall survival at 1 year, the difference between both arms is 6%. Then when you compare the difference at 18 years, the difference is 10%. And when you see the difference at 2 years, it's 15%. And you can see that 24% of the patients are alive at 2 years. And that's incredible in biliary tract cancer patients. So with these results, this drug, this strategy, gemcitabine, cisplatin, and durvalumab, it was approved by FDA and also by EMA. And I have to tell you that in those countries in which durvalumab is approved, it's the new standard treatment, gem, cis, and durvalumab. So unfortunately, in your country, in Jordan, it's not still approved. We hope you will have soon this drug available. But in the countries in which is approved, it is really the newest standard. Also, the trial consistently demonstrated the positivity of the secondary efficacy endpoint, progression-free survival, and also response rate. At the same time, or in later last year in ACR 2023, it was presented, Katie Kelly presented the results of this trial, Keynote 966, that is, they presented a similar design of the TOPAZ-1 trial, but the difference is that here patients were treated with pembrolizumab, gemcitabine, and cisplatin, or placebo gemcitabine and cisplatin. Patients stopped cisplatin at 6 months, but they continued with pembrolizumab, placebo, or gemcitabine, so without stopping the gemcitabine. Primary endpoint, overall survival, and as you can see here, this is again a positive trial, and I think that this trial is positive. It gives more consistently or reinforce the results of the TOPAZ-1 trial. Here the hazard ratio of 0.83, you can see that the curves are a little bit different. Here are separated from the beginning, and you can see that there is the same difference between both curves during all the evolution, without this huge benefit at 2 years. And then in this trial, we cannot see a difference, a statistically significant difference in PFS, neither in response rate. This is the huge difference between both trials. And we have more data of immunotherapy in biliary tract cancer. For example, we have this trial in Brave 151 that was presented 2 years ago in JSH committee and also was updated in the last JSH committee, in which patients in first-line biliary tract cancer were randomized to be treated with gem, cis, bevacizumab, and atezolizumab, or gem, cis, placebo, and atezolizumab. Primary endpoint, progression-free survival. And as you can see here, there was a tendency of better progression-free survival in those patients treated in the experimental arm with a hazard ratio of 0.76, but the difference were not statistically significant. Also, the overall survival was superior, not reached in the patients treated in the experimental arm, but with a hazard ratio of 0.74. So what it is interesting, and I want to share with you this publication that was very interesting because they analyzed more than 400 samples from biliary tract cancer patients, and they analyzed clinical, genomic, and translational data, and they can conclude that 30% of the patients with biliary tract cancer presented potentially actionable alterations, and also they divided the patients or the biliary tract in 4 different clusters, highlighting that the cluster 1 is the one that presented a more inflamed tumor with immune microenvironment. These patients in the cluster 1 were enriched with TP53, KRAS, and ITM mutations, and also enriched in intrahepatic cholangiocarcinoma and gallbladder. Also, they analyzed different immune markers like PD-L1, like TMB, and all these immune markers were higher in the gallbladder patient than in the rest of locations. And today we have different strategies in clinical trials trying to test the immunotherapy in biliary tract cancer patients, for example, bispecific antibodies or agonistic checkpoint antibodies or adaptive T-cell therapies, anti-PD-L1 or anti-PD-1 with the different combinations, and vaccines. And we hope in the next decade or in the next years, in the coming years, we can have results of all these strategies. Let's now to review the target therapy in biliary tract cancer, because today we know that not in first line, because we do not have any positive data of target therapies in first line, but we know that in second line or beyond, target therapy changed the treatment scenario in biliary tract cancer patients. We know that intrahepatic cholangiocarcinoma is one of the tumors with higher incidence of targetable alterations, being IDH1 mutation and FGFR2 fusions, the most common alterations in this disease. And also, in order to find these alterations, we must to do this NGS analysis at diagnosis of this disease. Why at diagnosis? Because to test NGS analysis, it takes time. Sometimes we have to repeat the biopsy. Sometimes we have to wait 3 or 4 weeks. So it's important to do it at the beginning of the tumor in order to have the results once the patient progresses to first line. We have to use tissue or we have to use liquid biopsy? That's a good question. So today, the standard of care is tissue. Why? Because the concordance between the tissue and the liquid biopsy is really high for the mutations, but it's really low for the fusions. So if you have a patient and you have tissue, you always have to use the tissue because the sensitivity to detect the FGFR fusions is higher. But if you don't have tissue and you don't have the possibility to have tissue, it's better to do a liquid biopsy than nothing, of course. Let's start with IDH1 as a target. The Clarity trial, it was a phase 3 clinical trial that included patients with cholangiocarcinoma and progression to first-line treatment with IDH1 mutation. And those patients were randomized to be treated to ivosidenib, the IDH1 inhibitor, or placebo. And the crossover was allowed because the patients' advocacy groups asked for it. The primary endpoint, so for this reason, it was progression-free survival. And this is a positive trial with a hazard ratio of 0.37. So a positive trial, and this treatment is approved by FDA and EMA. However, of course, we don't have a statistically significant difference in overall survival, and the reason why there's no difference is because 70% of the patients treated in the placebo arm cross over to the ivosidenib arm. Let's move now to FGFR inhibitors. Different single-arm phase 2 trial demonstrated promising activities in refractory cholangiocarcinoma patients with FGFR fusions, FGFR2 fusions. And I want to highlight, for example, the trial 5202 that demonstrated the activity of pemigatinib in patients with cholangiocarcinoma in a refractory setting. Those patients were treated in the FGFR2 fusions. There's another cohort in the trial with other FGFR alterations or with no FGFR alterations, and the primary endpoint with response rate. And you can see here that only the patients with FGFR2 fusions presented good responses, in fact, promising responses, 35.5% in patients with treated with pemigatinib. But when you see patients with other FGFR alterations or with no FGFR alterations, there's no activity with this drug. And also today we have new selective and irreversible FGFR2 inhibitors like this drug Relay 4008 that demonstrated a preliminary data with this response rate in patients previously treated with the standard of care and with FGFR2 fusions of 63%. So that's completely incredible and really active in this disease. Also, we have new tyrosine kinase inhibitors like tinengotinib that demonstrate activity in those patients with cholangiocarcinoma FGFR2 fusions treated after the treatment of other FGFR inhibitors. And you can see this, that is very interesting because it's in favor of this sequential treatment with different FGFR inhibitors. Now we are starting a phase 3 clinical trial in which patients with cholangiocarcinoma and FGFR2 fusions previously treated with pemigatinib or futibatinib can be included in the clinical trial and randomized to be treated with tinengatinib or chemotherapy. We will see. And the last target that I want to discuss with you is HER2. HER2 amplification is really common, not only in intrahepatic cholangiocarcinoma, but more in gallbladder, for example. We have different strategies that target the HER2 biliary tract cancer patients, the HER2 amplify or overexpress. You can see here the data that was presented and published in the last ASCO meeting. Zanidatamab is a bispecific antibody that targets HER2, and in this trial that they included 87 patients with HER2 amplified, and they reported a response rate of 40% when you are thinking that this is a really refractory population. 41.3% of patients respond to this treatment. Also, we have the data from the Pantumor 02. The Pantumor include patients with biliary tract cancer, but those patients treated with trastuzumab deruxtecan with immunohistochemistry 3+, they demonstrated a response rate of 56%. So it's completely incredible, and also a PFS of 7.4 months. So that's a good treatment option for this population. And finally, also, we have this basket trial in which one cohort of this basket trial is a patients with biliary tract and overexpression or amplification of HER2, and those patients were treated in a refractory setting with tucatinib, a tyrosine kinase inhibitor plus trastuzumab. And you can see here the response rates that presented the patients that were 46.7% with a median duration of response of 6 months. So again, HER2, I think it's clear that is a good target for these tumors. Here you can see the PFS of 5.5 months in this population and the overall survival of 15.5 a month. So I think it's really easy to ask for immunohistochemistry of HER2. It's not expensive, and I think it's a good target for our patients with biliary tract cancer, especially in those patients with gallbladder in which there is only few treatment options and are patients with really poor prognosis. So what says the international guidelines how we have to treat biliary tract cancer patients? ESMO guidelines recently, or in 2022, were published and recommend in those patients with advanced disease to do, first of all, molecular analysis, and without to wait the results, start the first line treatment option, cisplatin gemcitabine, and in those countries in which durvalumab is approved, to treat the patients with a combination of cis, gem, and durvalumab. In second line, if the patient presented a target therapy, those patients have to be treated with target therapy, but if the patient presented no targetable alteration, we have to treat the patient with 5-FU-based chemotherapy. What about the NCCN guidelines? First of all, NCCN guidelines recommend to test at least for NTRK fusion, for MSI, TMB high, BRAF, FGFR2 fusion, IDH1 mutation, HER2 overexpression and or amplification, and RET fusion. So those are the alterations that they believe it's a must in biliary tract cancer patients. In first line, they recommend to treat the patients with durvalumab, gemcitabine, and cisplatin, category 1, or pembrolizumab, gemcitabine, and cisplatin, category 1. And this is the newest standard in United States. What happened in second line? If the patient presented no targetable alterations, the preferable regimen is FOLFOX. And if the patient presented some targetable alteration, of course, we have the different target treatments. So, in conclusion, to sum up, biliary tract cancer is an heterogeneous group of different tumors with a poor prognosis. NGS is a must in all patients, especially at diagnosis, but we will use it in second line. Include patients always in clinical trial is a way to improve the prognosis of these patients and the treatment options. Gemcitabine, cisplatin, and immunotherapy is the new standard treatment in all those countries in which it is approved, but today we don't have biomarkers to select the patients that respond better to this therapy. And also we have the target therapy is a standard second-line treatment if there's some targetable alterations. The most important ones, IDH1 mutations, FGFR2 fusions, HER2 amplification or mutations, and BRAF V600E mutations. And today we have different clinical trials that are testing immunotherapy in combination with target therapy in first or in second line. So we will see if in the next decade we can change all the treatment scenario of this disease. With this also I want to invite all of you to the first ESMO gastrointestinal cancer that we will have this June in Munich, and all of you will be very welcome. And finally, I want to thank you for your attention, and here you have my email if you have any doubt. Thank you.
Thank you very much for your nice comprehensive talk. I have a couple of questions, please. Based on your experience and the updated results, do you think that durvalumab has a valuable addition to chemotherapy in the first-line setting? And is there any, given the immune checkpoint inhibitors are considered expensive medication, and the gain in survival is just a few months compared to chemotherapy alone? And do you have any difference between immune checkpoint inhibitors in the first-line setting, pembro or durvalumab? The second question, is carboplatin interchangeable with cisplatin in the first-line setting? And we know that from the comorbidity profile, we can't give cisplatin for each and every patient with biliary tract cancer. Thank you.
So very interesting questions. Thank you so much. First of all, so I think when we are evaluating the trials with immunotherapy, we have to learn that probably the median overall survival is not the best endpoint, because you can see here that the median overall survival are not so different between both arms. The important thing here is the tail of the curve. No, you can see how the curves are every time more and more separated. At the end, at 2 years, we have 50% of difference in overall survival between both arms. I think probably we have to change our mind and change our endpoints when we are talking about immunotherapy, and probably maybe we have to think in other endpoints, for example, 2 years overall survival. In fact, for example, ESMO benefit of scale, that it's a scale that ESMO used to give a number of the benefit of this new drug, give a number 4 out of 5 to this combination. Why? Not because we have a hazard ratio really less than 0.6, but because the main difference of overall survival between both arms is more than 10%. So we have to start to change our endpoints, because probably the median overall survival is not the best way to measure the benefit of durvalumab. My experience is I have good experience with both pembrolizumab and durvalumab. Globally, the results are really similar and confirms that immunotherapy in combination with chemotherapy is active in biliary. But the only thing is that pembrolizumab, the trial didn't present a benefit in PFS or response rate, so a little bit different in the results of the trial. But regarding side effects or my experience with the tolerability, it's really similar between both arms. Probably it will be a question of the access to the drugs that we will have in our countries or in our hospitals also, that will be important. But it's true that in the TOPAZ trial, we have benefit in overall survival, in PFS, and also in response rate. So there's a consistency in all the endpoints, and the keynote is only the benefit in overall survival. And the other question, there's a clinical trial today ongoing, that is the Tourmaline trial, that tests different chemotherapy strategies with durvalumab. For example, gemcitabine oxaliplatin plus durvalumab, gemcitabine carboplatin plus durvalumab, gemcitabine alone plus durvalumab, gem S1 plus durvalumab. And the reason why this trial is ongoing is in order to ask this question: no, can we interchange the chemotherapy with different components with durvalumab, no, and to see the efficacy and also the safety of these different combinations. We will see the data once we complete the trial.
I have also a question. With the shortage of randomized phase 3 trial in the adjuvant setting, what is your preferred regimen in resected pancreatic tumors?
The adjuvant treatment?
Yes, yes.
Yeah, so here I think our goal have to be to improve this adjuvant treatment that we have today. You know that we have the BILCAP trial, that it's a negative trial that tests the capecitabine as adjuvant therapy compared with observation. But then when they did a sensitivity analysis, they demonstrated that really the trial it was positive, but with this sensitivity analysis. So really is what we have when we try to demonstrate if gemcitabine, cisplatin, or gemox, it was active as an adjuvant treatment. The trials were negative. And today we are waiting the results of a phase 3 trial, that is the Attica trial, that randomized the patient in the adjuvant setting to be treated to capecitabine or gemcis, and we will see the results. Another important trial that is today ongoing, that is the Artemide trial, is a phase 3 trial that are testing the immunotherapy in the adjuvant setting. So patients after resection of biliary tract cancer are randomized to be treated with one drug of AstraZeneca, that is a bispecific antibody that targets PD-L1, but also TIGIT, so it's a very interesting drug, plus chemotherapy or chemotherapy alone. So I hope that with these new strategies, better than only chemotherapy, we can improve our adjuvant therapy, because today I think capecitabine is the only thing that we have, but it's not enough.
Thank you for your excellent contribution, Dr. Other questions? The person?
Nothing questions.
Any questions? No more questions. Thank you.
Thank you. Thank you.
Good morning, everyone. Good morning from Boston, anyway. I don't know what time it is where you are. I am Dr. Ada Wax. I'm going to be presenting the next session on HER2 expressing breast cancer, and I'm happy to be here. I don't know if anybody is going to say anything in between the sessions or introduce me, or I'll just share my screen and launch in.
Me, Dina Mary, and Dr. Ahmed Rifat will be moderating your next session, Dr. Adrienne Wax. She received her undergraduate degree from Princeton University in 2006 and her MD degree from Harvard School in 2011. Completed residency training in internal medicine at Brigham and Women's Hospital, where she subsequently served an additional year as a chief resident in internal medicine. Completed fellowship training in medical oncology at Dana-Farber Partners Cancer Care, then joined the staff of a breast oncology center at Dana-Farber Cancer. Today we'll be talking to us about a very interesting subject, from the traditional to transformation beyond black and white, thinking in HER2 expressing breast cancer. You can start.
Thank you so much. Thank you and good morning, everybody. Happy to join you from Boston. My name is Adrienne Wax, and yes, again, I'm from Dana-Farber Cancer Institute, particularly interested in HER2 positive and HER2 expressing breast cancer. So thank you very much for having me today. Here are my disclosures, and here's a disclaimer slide. So again, the talk is going to encompass all of what I'm going to call HER2 expressing breast cancer. And so there are really two sections. In the first section, we'll talk about HER2 positive metastatic breast cancer. And in the second section, we'll talk about the newer entity called HER2 low metastatic breast cancer, and go through the clinical management of both of those. So to launch into our first portion here, HER2 positive metastatic breast cancer, I'll go through the clinical management in, I think, just a straightforward way. We'll discuss first the standard first-line therapy, the current second-line therapy options, and then the sort of potpourri that we have at this point in the third line and beyond. So first-line therapy, not a lot has changed here in the last 10 or 15 years. We are still using the regimen that comes from the trial called Cleopatra, so we often call it the Cleopatra regimen. Cleopatra trial was done in about 800 patients who had HER2 positive metastatic breast cancer. This was their initial treatment for HER2 positive metastatic breast cancer, but it is of note that only about 10% had had prior trastuzumab in the adjuvant setting in this trial. So it didn't really reflect a modern population where a lot of patients may have a recurrent breast cancer with previous HER2-directed therapy. This was a little more like a de novo HER2 positive metastatic population these days. And so all of the patients received a taxane and trastuzumab, and the randomization was to placebo versus pertuzumab, the second anti-HER2 antibody. And we saw the original results of this trial published in the New England Journal in 2012, and then have followed these patients for many, many years and saw the final end of study results, which are shown here in 2020. And this was a positive trial. It showed a significant improvement in progression-free survival, a significant improvement in overall survival with the addition of the pertuzumab. You can see the median overall survival in this population in the pertuzumab arm is 57 months, so about 5 years. And the landmark overall survival rate in the pertuzumab arm at 8 years was 37%. So given these resoundingly positive results and incredibly long-term follow-up, THP is and remains at this point the standard first-line regimen for metastatic HER2 positive breast cancer. I think it's also notable and impressive, and I always like to point out that if you look not just at those very nice overall survival results, but also at the 8-year landmark progression-free survival. In the pertuzumab arm, there's actually 16% of patients who are still progression-free on their first-line regimen at the 8-year mark. And you can see that when you're out, many, many years here, the curve really doesn't necessarily seem to be dipping too much lower, which I think begs the provocative question of whether there's actually a proportion of HER2-positive metastatic breast cancer that we cure with systemic therapy alone. I actually think that that is the case, and obviously all of the exciting developments in this area hopefully will lead us to even bump that proportion up further. But I think that what we see in real practice is that there is a proportion of patients, even with just first-line THP, largely or exclusively with de novo HER2-positive metastatic breast cancer, who can actually be cured with a first-line regimen like THP. So not a lot has changed in that first-line setting. We're still using THP today, just like we were all the way back in 2012. But where there has been a lot of excitement and new developments in the treatment of HER2-positive metastatic breast cancer has been in the second-line space. And this has really been completely overhauled here in the United States over the last 5 years or so. So up until the past few years, TDM1 had a very firm hold as the second-line standard of care in HER2-positive metastatic breast cancer. And that has been based on the results of the Amelia trial. This was a trial that was published back in 2012, so over a decade ago, and compared what was at that time a new antibody-drug conjugate called TDM1 to a doublet regimen, capecitabine and lapatinib. And the TDM1 is the blue curves here, and you can see in these older data that TDM1 definitely beat the capecitabine lapatinib. It was better in terms of progression-free survival, shown on the left. It was better in terms of overall survival, shown on the right. And so the Amelia trial established TDM1 as the standard of care in the second line for HER2-positive metastatic breast cancer. And that was the case for about a decade until there was the development of a new antibody-drug conjugate called TDXD, or trastuzumab deruxtecan. And TDXD and TDM1 are both anti-HER2 antibody-based drug conjugates. They have a similar monoclonal antibody backbone, so that's quite similar between the two, but there are important differences between them that you can see outlined here that, as you'll see, translate into a very large difference in efficacy. So to highlight some of those differences, TDXD has a different cytotoxic chemotherapy payload. It has a topoisomerase 1 inhibitor, as opposed to TDM1, which has the M-tansine microtubule inhibitor. The drug-to-antibody ratio is higher for TDXD, so it's a drug-to-antibody ratio of 8-to-1, as opposed to more like 4-to-1 for TDM1. So there's more payload on each antibody in the TDXD. And then, I think potentially most importantly, and you'll see over the course of the lecture how this comes up in a couple of different contexts. Most importantly, TDXD is different because it has this tumor-selective cleavable linker technology, and it displays this evidence of a bystander anti-tumor effect, and TDM1 doesn't do either of those things. And we talk about the bystander effect a lot. What we mean when we talk about that is that the TDXD, when it goes to a HER2-positive breast cancer cell and the antibody, attaches onto the HER2 target and brings the payload there, because there's this cleavable linker, some of that payload gets cleaved off of the HER2-directed antibody. And then, some of it will go into the HER2-positive breast cancer cell, but some of it can diffuse or travel to the nearby neighboring cells, even if those cells are HER2 negative and don't express HER2 protein, and it can kill those bystander cells because of this cleaved off payload. And that is probably a very important difference between the two antibody drug conjugates, the fact that we see this bystander effect. So the most important initial randomized phase 3 study of TDXD in HER2-positive metastatic breast cancer was the DESTINY-Breast03 trial, and the schema for that trial is shown here. In this trial, about 500 patients were randomized to the comparison of TDXD or TDM1. This was basically a second-line HER2-positive metastatic trial, so trying to take the Amelia trial and then build upon it, essentially. And here are the baseline characteristics of, again, about 500 patients who participated in the trial, a pretty standard second line or so population. I will focus a little bit on brain metastases here. We know that this is a particularly important problem in patients with HER2 positive metastatic breast cancer. And so just to point out that brain mets were represented in this trial in about 20% of patients or so, and all of those patients had stable brain metastases. So these were previously treated stable brain metastases in about 20% of patients. And I highlight that here just to compare to some other trials later on. So this trial was resoundingly positive. You might have seen these curves before, but TDXD was much better than TDM1 in terms of a primary endpoint of progression-free survival. There was a median PFS of almost 29 months, so over 2 years with the TDXD, as compared to the pretty standard duration that we see with TDM1 of more like 7 months. So a hazard ratio of 0.33 in favor of the TDXD, and you can see the wide separation of the curves here. Also, that impressive difference in progression-free survival translated into a significant overall survival benefit as well in favor of the TDXD with a hazard ratio of 0.64. So both a PFS and an OS advantage for TDXD over TDM1 in this largely second-line HER2 positive metastatic population. As I showed you, brain metastases were not terribly well represented in the DESTINY-Breast03 trial, and none of the patients in that trial had what's called active brain metastases. But again, since this is such an important population within HER2-positive metastatic breast cancer, just to highlight for you here a couple of smaller cohorts that have looked at the CNS activity of TDXD for patients who have breast cancer, in this case all HER2-positive breast cancer, and active brain metastases. And just to be clear, when I say active brain metastases, what I mean is patients who have either never had local therapy to their brain metastasis, so it's newly diagnosed and they haven't undergone radiation plus or minus surgery, or patients who did do those local therapies, CNS-directed therapies in the past, and now nonetheless still have progression of their brain metastases. So that's what I mean when I'm talking about active brain mets here, as opposed to stable brain mets. And as you can see, these are pretty small cohorts, but in these 3 cohorts, there was nice, consistent, impressive activity of the TDXD in these patients with active brain metastases. So we have some early data that's definitely suggestive of activity even in the setting of active brain metastases. And as you may know well, so the most important toxicity to keep in mind with TDXD across all trials, these data are from the DESTINY-Breast03 trial, is the risk of pneumonitis. And pneumonitis in DESTINY-Breast03 was seen in about 11% of patients. This is pretty consistent when you look at any TDXD-treated population. So this is, reasonably common, something that's important to keep in mind. In this trial, you can see all of the events were grade 1, 2, or 3. There weren't any grade 4 or grade 5 events. We have seen, and I'll show in some later data, that in some other trials of TDXD, there can be about a 1% rate of grade 5 or fatal pneumonitis with TDXD, which is why we harp so much on this side effect, the detection of the side effect and its management, because if not managed adequately, it can become very serious, but we know that it is quite manageable. I think an important thing also to keep in mind about the pneumonitis associated with TDXD is that the median time to its onset is a number of months, about 5 months in the DESTINY-Breast03 trial, and that's, again, been seen in all of the trials consistently. And so, of course, it's something important to keep in mind from the first time that you dose the patient with TDXD, but it's actually just as important and potentially more important to keep in mind many months into their treatment course. You can't sort of take it off your radar if they've been doing well for a couple of months, because actually that's when it's more likely to come up. Because this side effect has, gotten a lot of attention and obviously needs, again, very proactive management, just a couple of slides and some resources on how to think about its detection and its management. This is a nice review article in JCO Oncology Practice by two of my colleagues, and I won't go through it in great detail, but it's, I think, a good reference when you're treating patients with TDXD and a good mnemonic to keep in mind. This is the 5S rule for the management of TDXD-associated pneumonitis, just underscoring it's important to screen patients symptomatically. Are you having cough? Are you having shortness of breath? Scan frequently to look for radiographic evidence, act synergistically with a multidisciplinary team like pulmonologists, always suspend treatment, stop the TDXD if this is something that you expect, and treat with steroids. And a sort of more quick and dirty way of approaching it, really when I'm faced with this problem, I always just Google TDXD pneumonitis. This is the result that you find, and it guides you in what you should do here. And the important distinction here in terms of managing what you suspect could be pneumonitis is whether the patient is symptomatic or asymptomatic. So if they're asymptomatic, that's a grade 1 pneumonitis. You can consider steroids. I will say I always do give steroids for grade 1 pneumonitis. And you can interrupt. You have to interrupt the TDXD. But if it resolves radiographically, then you can resume the treatment. By contrast, if they have any symptoms at all that you suspect are from the pneumonitis, so that would make it a grade 2 or higher diagnosis, then you always initiate steroids and you cannot re-challenge with the drug in any circumstances. So that symptomatic versus asymptomatic distinction is a very important one, and very important to be doing frequent chest CTs to radiographically monitor for the pneumonitis so that you can hopefully pick it up sooner rather than later, and then potentially have the opportunity to re-challenge the patient as long as they haven't developed symptoms. And just to note, as I mentioned in that first-line therapy section, Cleopatra or THP remains the current first-line standard therapy, but there has now been completed enrollment to the DESTINY-Breast09 trial. And in this trial, basically, investigators are looking to understand whether TDXD should replace THP as a standard first-line therapy. So the randomization here is to TDXD by itself, TDXD plus pertuzumab, or the standard Cleopatra THP in the first-line setting for HER2-positive metastatic breast cancer. And again, this trial has completed enrollment, but presumably will take some time to read out. So we don't have this result yet, but something to keep our eyes out for in the years to come. All right, let's move on, still in the second-line setting, more or less, and talk about tyrosine kinase inhibitors and HER2-positive breast cancer, and especially the most recently developed of them, which is tucatinib. So as you know, and as are listed here, there are many anti-HER2 tyrosine kinase inhibitors that are in widespread use. Tucatinib, like some of the others, is a reversible, has reversible binding to the HER2 receptor. But importantly, and in distinction to all of the others that you can see in the table, tucatinib is the most HER2 specific. So it has the most on-target efficacy and the fewest off-target side effects. So that sort of biochemically is what's special and important about tucatinib. So tucatinib was looked at initially, or in the largest experience, in the HER2-CLIMB trial. And this was a trial more or less for patients in the third-line setting with HER2-positive metastatic breast cancer. So this is a later line population than the DESTINY-Breast03 trial that I showed. And these patients were randomized all to receive trastuzumab plus capecitabine. And then the randomization was to the tucatinib drug or placebo. And this trial was published in the New England Journal of Medicine in 2020 and met its primary endpoint. It showed a significant improvement in progression-free survival with the tucatinib. You can see that here. The blue curve is the tucatinib arm with a 7.8-month median PFS versus 5.6 months if you just got the capecitabine plus trastuzumab control arm. And also, importantly, there was an overall significant overall survival benefit here for this combination, this triplet combination as well. So based on these results in 2020, this agent entered widespread use as part of this triplet regimen a couple of years ago. And I think the really important thing to note about the HER2-CLIMB trial and about tucatinib in general is its impressive activity and its track record and evidence in patients who have brain metastases. So the HER2CLIMB trial was about a 600 patient trial. And in that 600 patient trial, about half of the patients had brain metastases. And of those, actually, the majority had active brain metastases, those ones that were previously untreated or previously treated and progressing after local therapy. And then another third or so had the treated and stable brain metastases. So this trial was really sort of revolutionary in terms of how well represented patients with brain metastases were. And, I'll show you those results in a moment, but, I think it led to a particularly important role for this agent in patients with HER2-positive breast cancer brain metastases, and really a push in the field that as we design these clinical trials in all subsets of metastatic breast cancer, but especially HER2-positive metastatic breast cancer, we have got to be more thoughtful and more inclusive of these patients with brain metastases, because in clinical practice, this is a large proportion of our patients. We know that HER2-positive breast cancer in the metastatic setting, ultimately about 50% of those patients will develop brain mets. So when looking just at the subpopulation of patients with brain metastases, again, this was about 300 of the 600 patient trial, there was a significant improvement again in overall survival on the tucatinib arm of the trial, with a median overall survival advantage of 9.1 months in the tucatinib arm among this brain metastasis population. So, a very clinically meaningful impact of the addition of tucatinib in the brain metastasis population. And just breaking that down into the two subgroups, it's basically the same result if you look at the patients who had active brain metastases, shown here, and if you look at the patients who had stable brain metastases, shown here. So really consistent between those two groups. So that brings me to sort of the final thought and conclusion in this second-line therapy setting. Are there scenarios where T-DXd may not be the right second-line choice for our patients? And so, I think one of these situations is the patients with active brain metastases, where we can think about them on a case-by-case basis. I showed you some data for T-DXd in active brain metastasis patients. You can recall those were smaller cohorts, but the data looked very promising and consistent with the excellent activity that we see with that agent outside the CMS. HER2CLIMB had a sort of deeper dive into the brain metastasis population and showed that impressive overall survival benefit. So I would say that on the basis of the evidence we have right now, both T-DXd and the HER2CLIMB regimen are absolutely reasonable options. But I would say HER2CLIMB has a particularly strong evidence basis in patients who really have CNS predominant disease. And then for patients who have any history of pneumonitis or interstitial lung disease, at this point, unfortunately, we really can't give them T-DXd. So that's a population where T-DXd is not under consideration. I think otherwise, on the basis of the DESTINY-Breast03 trial, at this point, T-DXd is the default choice in the second line for HER2-positive metastatic breast cancer. All right, so let's move on to the third line setting. And, here we get really into what I would call a data-free zone. We have a number of different options. You can mix and match in all sorts of ways. I'll try to summarize some of the updates and evidence in this space, but there really are a lot of right answers. And so, you use the side effect profiles and your experience with the patient to do the best that you can. And the good news is that we know many of these patients with HER2-positive metastatic breast cancer get many, many lines of therapy and can do well for a very long time. But we really don't know, assuming that our patients by and large are going to be getting T-DXd in the second line setting, we really don't have any data about how different regimens perform post T-DXd. So it's hard to predict for patients what they're going to get in terms of progression-free and overall survival at this point following T-DXd exposure. So I wanted to highlight one study that was just presented in December at the San Antonio Breast Cancer Conference, which was the HER2CLIMB-02 study. This was looking at a different way of using the agent tucatinib. This was, again, HER2-positive metastatic breast cancer, approximately a second-line population. Prior TDXD was not allowed on this trial, and it was a randomization between TDM1 plus or minus tucatinib. This trial did meet its primary endpoint of progression-free survival. The TDM1 plus tucatinib arm, the doublet arm, is shown in blue here. You can see it's tracking above that purple line with a PFS difference of about 2 months. So it's somewhat of a modest improvement for sure, but it was statistically significant. 7.4 to 9.5 month improvement in the median progression-free survival. There was no overall survival benefit seen. Those data were presented, but I'm not showing them here. But those data are immature. And then again, I think especially important in tucatinib trials, they've done a great job at looking at patients specifically with brain metastases. These are the patients who participated in HER2CLIMB-02 and had brain metastases. And again, you can see that the results track pretty much with the overall population, where there was about a 2-month improvement in the median progression-free survival for this brain metastasis population. So, I think that this was an interesting trial and an interesting presentation just 2 months ago, helping us think about another way to combine doublet HER2 blockade in a way that maybe is an option for our patients. At this point, I don't think that this replaces the HER2CLIMB regimen in any way. For one thing, this regimen is not FDA approved. It was just presented as an oral presentation, again, 2 months ago or so. We haven't seen a full publication about it. And it doesn't have yet that overall survival advantage that the HER2CLIMB original trial does. So this is not like a replacement regimen for HER2CLIMB by any means at this point. But it was a positive trial, maybe for a subset of patients for toxicity-related reasons. It's an alternative option that we might consider in the future as a way to use tucatinib. It also raises a very important question about all of these HER2 TKIs, which is how can we use them in sequence? Should you use tucatinib again with a different partner in a patient who got it previously? What about if you're using neratinib after tucatinib? And the answer to that is that we really don't have much data in that space. There is some preclinical data that an alternative TKI can work after a first TKI, that, for example, neratinib may work on a molecular basis, at least, after tucatinib. But in terms of clinical data, we really don't know what we get out of these TKIs when we use them one after another. And so on that note, let's move to neratinib. This is another anti-HER2 TKI. This is much less specific than the tucatinib drug. And again, in the preclinical setting, that leads to potentially some evidence that it can work and have efficacy after a patient has progressed on tucatinib, but we don't really know that clinically. The main important side effect to know about this drug, as I'm sure anyone who's used it is aware of, is the potential to cause diarrhea. We know that dose escalation can help to mitigate that. And just to sort of remind you about these important data, focused on neratinib, which come from the NALA trial. This was a phase 3 trial that compared neratinib plus capecitabine versus lapatinib plus capecitabine. Those results are shown here, and the neratinib arm was the winner in this trial with an improvement in PFS compared to lapatinib. So I put this slide in and a reminder of this trial just to say, as a reminder, when we're choosing between neratinib and lapatinib, we do actually have this head-to-head comparison, and neratinib was the winner here. There's a novel anti-HER2 antibody called margetuximab. I will say, even in the United States, this is not in widespread use, but it's an interesting agent mechanistically and something that we can think about in more refractory later line HER2 positive metastatic populations. So margetuximab is very similar to trastuzumab. It is an anti-HER2 antibody that has just 5 amino acids changed compared to trastuzumab. And those amino acids were engineered that way in order to make this a more immune activating and a less immune suppressive anti-HER2 antibody. So what I always describe to patients is, margetuximab is not an immunotherapy in the traditional sense of the word when we say immunotherapy, but it was engineered to try to be an immunologically optimized or an immunologically charged version of trastuzumab. And in the SOPHIA trial, there was a head-to-head comparison between margetuximab plus chemo and trastuzumab plus chemo in a later line HER2 positive metastatic population. And there was again, we would have to call this quite modest, but statistically significant improvement in median PFS with the margetuximab over the trastuzumab from 4.9 months to 5.8 months, a hazard ratio of 0.76. And so, I think this is an interesting agent to use in a later line patient when you are switching out, HER2 antibody and different chemotherapy backbones. I use this in place of trastuzumab in some cases. Toxicity is exactly the same as trastuzumab and very minimal. And then a final special subpopulation to highlight, and one that's, not so rare at all, but yet that we have very few dedicated trials in, is the triple positive metastatic population. So a patient who's both ER positive and HER2 positive. We often end up treating that patient over and over again with HER2 targeted regimens. But at the end of the day, I think ask ourselves very frequently, should we be using, and what would the efficacy be if we were using more of an endocrine type of strategy for those patients? And so the MONARCH-HER trial, which wasn't a randomized phase 3 trial, this is a randomized phase 2 trial, but this randomized phase 2 trial tried to get at that question in a later line HER2 positive metastatic population that's also ER positive. So in this trial, patients were randomized to an arm that was abemaciclib plus trastuzumab plus fulvestrant. So it's a completely chemo-sparing regimen, but bringing in the CDK4/6 inhibitor abemaciclib, versus a sort of a strange comparator arm, which was just abemaciclib plus trastuzumab. I won't focus on that one much. And then just a control arm, which was trastuzumab plus an investigator's choice of chemotherapy. The primary endpoint here was progression-free survival. And this trial did meet its primary endpoint. It showed a progression-free survival advantage for arm A, which again was that triplet of abemaciclib plus fulvestrant plus trastuzumab compared to chemo plus trastuzumab, with an improvement from 5.7 to 8.3 months in the median PFS. And so I think this is just a nice reminder and a sort of call to action, actually, that we need to be more thoughtful, we need to design more trials, and we can use agents from the ER positive metastatic space for these patients who have the triple positive metastatic cancer, spare them, spare these patients ongoing chemotherapy toxicities, and potentially actually get better efficacy out of our regimens as well. So with that, to wrap up this first portion and just sort of summarize, at least in the US, our current standard of care for HER2 positive metastatic disease. So again, first line is still THP. Nothing has changed that for over a decade. Potentially DESTINY-Breast09 could bring T-DXd into the first line, but it will be a number of years, presumably, till we see those results. In the second line setting, T-DXd is the standard of care, although you might consider tucatinib, trastuzumab, capecitabine in patients who have really intracranial predominant disease or had a history, for whatever reason, of previous pneumonitis or ILD. In the third line setting, things get a lot messier. You have a lot of options. You loop back to whatever you didn't use in the second line, could use TDM1, could consider that HER2 CLIMB-02 regimen of TDM1 plus tucatinib, although again, I would definitely prioritize that lower than the original HER2 CLIMB regimen at this point. And then really end up in the fourth line and beyond with a dealer's choice of all sorts of different combinations. You can slot in margetuximab with chemo. You could go to a different TKI like neratinib plus capecitabine. We have many different chemo partners that are listed here. And then the special consideration in a patient who's hormone receptor positive and HER2 positive of the monarch-HER regimen, fulvestrant plus abema plus trastuzumab, which I think is a great option for these patients. And patients are always, of course, excited to omit chemotherapy for a period of time. And this is just the same thing, reiterated a different way. This is the NCCN guideline updated last month for HER2 positive metastatic breast cancer. Again, THP standard first line, TDXD standard second line. In the third line, HER2 climb has the preferred indication, TDM1 also a consideration, and then many, many different options when you get into the fourth line and beyond. Okay, so with that, let me check the time. Perfect. And then transition into the second portion of the talk, talking about a much newer entity, some more like hot off the press information. So this is HER2 low metastatic breast cancer. And here we will start with what is HER2 low status? Why does it matter? We'll talk about there's only one practice-changing trial in this area, which is the DESTINY-Breast04 trial. And then just try to address some practical concerns about when do we assess HER2 low status, how do we report it, how do our pathologist colleagues help us get this information so that it's useful to us. Okay, so what is HER2 low status? Why does it matter? So this is not news. We've known for a long time that HER2 negative tumors express some degree of HER2 protein, and for many, many years, decades, we have seen that quantified as a HER2 IHC, immunohistochemistry score, of either 1+ or 2+. And it's also not a new question. We've asked decades ago, could those patients who have a little bit of HER2 benefit from HER2 blockade? We've asked that question before in large randomized phase 3 trials that had been previously negative. So the NSABP-B47 trial, for example, was a large phase 3 trial that was originally conducted to understand if adjuvant trastuzumab could be a good option, could improve outcomes for HER2 low breast cancer patients. These were high-risk early-stage patients who, again, had IHC 1+ or 2+, and were FISH negative for HER2, so this was the old HER2 low categorization. Patients were randomized to a standard chemo regimen plus or minus adjuvant trastuzumab. And in this randomized phase 3 trial, there was absolutely no benefit of adding trastuzumab for these HER2 low patients. You can see here that the red and the blue curves are basically purple because they're completely overlapping. There was no benefit of adjuvant trastuzumab in the HER2 low population. So what changed? Why did we start asking this question again and start caring about this categorization again? So what changed was that at the ASCO annual meeting conference in 2018, there were these exciting provocative data shown that looked like the agent TDXD potentially did have activity in HER2 low metastatic breast cancer, the first time that we'd seen evidence for HER2 targeted agent in a non-HER2 positive population. And so this is the waterfall plot from that initial cohort. This is about obviously 50 patients who were treated with TDXD with either IHC 1+ or IHC 2+ and FISH negative metastatic breast cancer, so what we are now, what we call HER2 low. And you can see in the waterfall plot, the results of this agent were impressive. You saw both in the IHC 1+ and in the IHC 2+ patients, very nice responses with the TDXD, overall response rate of 37%, median PFS of 11 months in this heavily pretreated phase 1 population with HER2 low disease. So again, this was very provocative, quite different from what we'd seen in the years prior. And again, we think that on a molecular level, that probably the reason that TDXD acts differently from all those other HER2-targeted agents that we had tried in HER2 low disease and hadn't worked, like trastuzumab, like TDM1, is this evidence of its bystander effect. So we assume that TDXD is working here because that payload can diffuse to HER2 negative, HER2 non-expressing breast cancer cells, as long as there are a few HER2 positive cells in the mix there. So that's, again, why that bystander effect comes up as such an important biochemical distinction of this agent. So it became clear that we needed a new approach to defining HER2 status, and this, as of 2020 and still in use today, is the paradigm that we use now to define HER2 status that's clinically meaningful for our patients. So this red part of the pie chart, which is the true HER2 positive patients, this hasn't changed at all. The definition of HER2 positivity is exactly the same. You have to be IHC3 plus or have a positive a positive ISH result. That proportion of patients remains about 15 to 20%, and that definition hasn't changed at all. HER2 negative breast cancer, which is just IHC 0 at this point, that immunohistochemical designation has stayed the same. It may change in years to come. There are some other trials coming that we might even have to reevaluate this HER2 negative category. But for now, IHC 0 is just HER2 negative. And what's new is this brown category in the middle called HER2 low, which is, again, those people who have either an IHC 1 plus result or have an IHC 2 plus and go on to that ISH in situ hybridization testing and have a negative result. And it's important to say this is a very common prevalent population. This is not a rare biomarker. We know that approximately half, or actually a little more than half, of all breast cancer is HER2 low. So this is a very prevalent population. And so the practice-changing trial that we have in this HER2 low population is the DESTINY-Breast04 trial. Here's the schema for DESTINY-Breast04. This was a randomized phase 3 trial in patients with HER2 low metastatic breast cancer treated with 1 or 2 prior lines of chemotherapy. And these patients were randomized between TDXD or a chemotherapy of physician's choice. And these are the options: capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. It's important to note, and I'll say this a number of times, so this was about a 550 patient trial. The large majority of the population were hormone receptor positive HER2 low patients. There was a much smaller cohort of hormone receptor negative HER2 low patients, about 60 patients in total, but they were much less well represented in this population. It was mostly hormone receptor positive HER2 low disease. Here are the patient characteristics, again, more or less a 550 patient trial, and main thing to underscore here is that it was 90% hormone receptor positive. So the triple negative patients, meaning hormone receptor negative HER2 low, were only about 10% of the population overall. Couple other things to highlight about this population. So this was largely a second-line chemotherapy trial. You can see that reflected here. Median lines of prior chemo was usually 1. Median lines of prior endocrine therapy was usually about 2. And about 70% of these patients had received a prior CDK4/6 inhibitor. The primary endpoint of this trial, and it very nicely met its primary endpoint, was the progression-free survival in the hormone receptor positive population. So that was the primary endpoint here. It's highlighted for you in the red box. Again, the trial met its primary endpoint pretty impressively. There was a significant improvement in median progression-free survival among the hormone receptor positive patients from 4.2 months from the standard chemotherapy choices to 9.6 months with TDXD for a hazard ratio of 0.37. And then if you look in the all patient population, so combining the hormone receptor positive and the triple negative, it was about the same thing, 4.2 to 8.8 months, hazard ratio of 0.36 with the inclusion of those triple negative patients. There was also, importantly, an overall survival advantage seen in the hormone receptor positive and the overall population. Very clinically meaningful improvement in overall survival from 17.6 months to about 24 months from the standard chemo to the TDXD, and really approximately the same number seen if you brought in those triple negative patients as well. And then the results that were shown in that dedicated triple negative HER2 low population, again, that was only about 60 patients. These results were only exploratory. There weren't, p-values or anything like this because this was a small exploratory cohort. But you can see nonetheless that the results were quite consistent with what the overall trial had shown, with a significant, well, I shouldn't say significant because it wasn't tested statistically, but a numerical improvement in overall survival here, a numerical improvement in progression-free survival, and basically consistent hazard ratios. Not surprisingly, given those results, we also saw improvement in the overall response rate with the TDXD compared to the standard chemo. The response rate to TDXD was 53% in the hormone receptor negative, hormone receptor positive patients versus about 16-17% for the treatment of physician's choice. So improved overall response rate as well. And in these waterfall plots, I just show for the TDXD on the left here to point out the IHC1 plus are the dark blue, the IHC2 plus are the light blue. As you can see, it didn't look to matter at all whether you were IHC1 plus or 2 plus here. So the degree of how HER2 low you were did not seem to make any difference. TDXD worked well regardless here. Just to highlight again toxicities to keep in mind with this drug. So didn't highlight this in DESTINY-Breast03, but it was exactly the same in that trial. In clinical terms, in the clinic, in terms of things you might commonly see for these patients, nausea is really the most common side effect. And you can see 73% of patients here had any grade of and had grade 3 or higher. And in the United States, we treat this and we pre-medicate for TDXD as a highly emetogenic regimen. So just like AC or something like that. If you don't, some patients can definitely experience significant nausea, but it's manageable just like it is with other agents. And then the pneumonitis results in the DESTINY-Breast04 trial really completely mirrored what was seen in the DESTINY-Breast03 trial, about a 12% rate of pneumonitis, and here, as unfortunately has been seen in other cohorts, about a 1% rate of grade 5 or fatal pneumonitis. So again, I won't rehash what I said earlier about managing and detecting and keeping top of mind, but we know that it can be very serious if not picked up and managed quite proactively. So on the basis of these DESTINY-Breast04 trial results, the United States FDA approved in HER2 low breast cancer in the second line and beyond about 18 months ago. And in Europe, it was approved about a year ago in the same indication. And so let me end in the last few minutes with just a practical note about when should we assess HER2 low status, how should we assess it, because now we have this DESTINY-Breast04 results. This is a biomarker that we need to keep in mind for all of our patients with metastatic breast cancer. The most important point to make here is that we know, and it's been shown now many, many times in the last couple of years since we've started using this agent, that HER2 low status is unstable. It changes frequently over time. And so, if you have a primary tumor, that the HER2 IHC status can differ from the first metastatic recurrence, which can differ from the second, metastatic time point tested. You can see switches in terms of IHC 0, IHC 1 plus, IHC 2 plus very, very frequently. So this is an unstable biomarker. And then, importantly, since it does change over time, the question is, okay, so if my HER2 was 0 on my most recent specimen, but it was 1 plus, 10 years ago when the patient had their primary tumor resected, are they still a candidate for an agent like TDXD? And there have been many attempts to try to answer and understand that question. And basically, it looks like the answer is yes. TDXD seems to be effective regardless of when the HER2 low status was ascertained. So in DESTINY-Breast04, actually in about 2/3 of the patients, the HER2 low IHC had been positive or had been in the low range on their primary tumor before their metastatic disease. It was a little more than half where it was tested on a metastasis. And regardless of when that HER2 low status was ascertained, whether it was the primary or the metastatic tumor, the hazard ratio for TDXD benefit was consistent. You can see here 0.47, 0.5. So on the basis of these results, as of now, and international guidelines actually support this and have written it in, we use TDXD regardless of when the HER2 low status was ascertained. And the important corollary here is that it is really important now to report HER2 IHC on any breast cancer specimen that gets tested. You don't want just the ISH result. And if you're considering this as a potential agent for a patient in the metastatic setting and it wasn't tested on their primary tumor, you actually want to go back and ask your pathologist to dig that out of the vault from 5-10 years ago, whatever, and test it because it could make a difference for their current treatment. And again, just to wrap up, here's the NCCN guidelines 2024 for hormone receptor positive and HER2 negative metastatic breast cancer that do note they recommend TDXD in the second line for those patients who are HER2 low. It's the same thing in the triple negative metastatic breast cancer NCCN guidelines 2024. If you have HER2 low biomarker, TDXD is a recommended agent in the second line. And so to close with this second section of HER2 low metastatic breast cancer, this is a prevalent population. Approximately half of breast cancer is HER2 low, so this comes up all the time for us. Based on those DESTINY-Breast04 trial results, TDXD today is positioned as the standard of care for second-line chemo in many patients with HER2 low metastatic breast cancer. An important caveat here is that the triple negative cohort in DESTINY-Breast04, as I showed you, was small. We have other antibody drug conjugates, sacituzumab govitecan, that have been tested in larger dedicated triple negative populations and shown impressive efficacy. And I think that that's important to keep in mind. So this in the triple negative population, this is not the only antibody drug conjugate that's positioned here. Sacituzumab is an important alternative consideration. But with that caveat, the triple negative HER2 low results in DESTINY-Breast04 were consistent with the overall population. We know that an assessment of HER2 low status at any time point, the primary tumor, the early metastatic, the late metastatic tumor, is adequate to make a recommendation for TDXD therapy. So we do need to ask our pathologist colleagues to test this over and over again. Just to rehash that, given the clinical implications of this HER2 low status, HER2 IHC now needs to be assessed on all breast cancer pathology reports. And so with that, I'll wrap up. I thank you for your attention. I'll stop sharing if that makes it easier to ask questions.
Thank you very much, Dr. Bach, for this updated and comprehensive lecture. If you allow me, I have one practical question.
Please.
For a patient HER2 positive metastatic breast cancer with a second line of treatment, in case of isolated CNS progression, do you recommend to change his protocol or keep going until disease progression, especially when these new drugs are not available? What's your opinion, please?
Yeah, I think that's a great question. I didn't hear what you said with the especially, but can you say just the very last part?
Especially when these drugs like TDXD is not available.
Oh, yeah, exactly. Right. So, even in the US, where I'm in my clinic, where I do have TDXD available, when I have somebody who's on THP and they have, their first line therapy and they have isolated CNS progression, I do local therapy to the CNS and I do not change their systemic therapy. That's even with TDXD, to, HER2 climb, all of that available. We don't take them off. I would say, there's not like a randomized phase 3 trial to guide us here, but our standard of care would be to do whatever local therapy is appropriate, radiation plus or minus surgery, and keep them on their HP maintenance, obviously now with, brain MRI surveillance and stuff like that. You could say, well, okay, that's very easy, I think, if it's like one or two small things or one big thing that you can just resect. What if they present with 20 brain metastases everywhere, and you're looking at whole brain radiation? That's a different situation. Then that patient, I would probably even switch to HER2 climb, honestly. But yeah, isolated CNS progression, I would keep them on their HP. There's a very important question about, where we have a trial going on that's being run in the United States right now to ask, should you keep them on HP and add tucatinib in that patient? I think that's an attractive thing to think about doing. You radiate their brain met, you keep them on HP, and you add tucatinib. We don't know if that's the right thing to do, but we do have a trial going on to look at that right now. But as of now, I wouldn't do that. I would just radiate, do surgery, and keep your HP going.
Dr. Mohammed Salam, please, your question. Unmute, please.
Now?
Yes, تفضل دكتور محمد please.
Can I ask instead?
Dr. Maher?
Yes, thank you for this is really comprehensive, about HER2. So my question is, have TDXD ever tried on patients with HER2 ultra low, meaning between 0 and 1+, or even on the 0? Because, for us, I'm a pathologist, the CAP ASCO guideline still says, there is a caveat. This has not been tried, but we have to mention the ultra, the low, the 1+ and 2+, but it doesn't mean that really it matches or has been proven as an evidence for the 0 versus the 1+ or the ultra low. Thank you.
Yeah, no, that is a fantastic question, and it brings up two important points that I didn't go into detail on. First to answer your question in the most straightforward way, we don't have any good evidence to do what you're suggesting, which is to use TDXD at this point in a HER2 ultra low population. But there is a trial going on. I believe it might have completed accrual, but it certainly hasn't read out yet, called DESTINY-Breast06, and it's doing exactly what you just said. It's taking a population of patients who are metastatic, hormone receptor positive. In this case, they're all hormone receptor positive, HER2 low. They're all hormone receptor positive, HER2 low, but they're in this special category of ultra low, where they're between absolute 0 and 1+. So they're being assessed. You have to have something. You have to have a little bit of HER2, but you can be between, basically a tiny bit and still under 1+. So HER2 ultra low is this new category being looked at in DESTINY-Breast06. And if that is a positive trial, then it would bring TDXD into that ultra low HER2 category as well. That's kind of what I was referring to when I said right now we call HER2 negative IH, completely negative IHC 0, but that actually might change because if DESTINY-Breast06 is a positive trial, and we should know that relatively soon, we're going to have to further break out an ultra low category where we use it and a completely 0 category where we don't. So that's one thing. Stay tuned for DESTINY-Breast06 to understand the clinical implications of your question. The second answer to your question is that it has been shown over and over again that the correlation between pathologists, including trained breast pathologists, in assessing HER2 low status is terrible. The correspondence between one pathologist calling something 2+, one calling it 0, one calling it 1+, has been shown to be terrible. That's because our current HER2 assays were not designed to distinguish 0, 1+ from 2+. They were designed to distinguish 3+ from everything else. And so there's a lot of interest in developing better, more quantitative HER2 testing that works at those low ranges to help us figure out, when we should be using drugs like TDXD. There's a ton of interest in that. None of it has any, clinical implications as of yet, but both of those are important areas of development for medical oncologists and pathologists. So thanks for that question.
Dr. Mohammed Salam, please. Your question. تفضل. No more questions. Okay, thank you again, Dr. Watts. And
Thank
we
you
hope
so
to
much.
see you, Jordan. Thank you very much.
Have a great day, everyone. Thank you.
Everybody for participation.
كانه زي هذه موجودة فاهم عليك في دقيقة واحدة لا لأني واحد محمد بس أنا عندي موجود بس إذا موجود ورقة
biopsy all the time, and
Okay, assalamu alaikum. Welcome everybody. Our next session is a BMT session. We are honored to introduce our speaker, Dr. Mohammed Monti. He is full professor of hematology and head of hematology and cellular therapy department at San Antonio Hospital and Sorbonne University in Paris. He obtained his medical degree from the University of Contemplaire in France and PhD from University of Marseille. He is also head of translational research team in CERN at San Antonio Research Center in Paris. Dr. Mufti is the past president of the European Society for Blood and Marrow Transplantation and past chairman of the Acute Leukemia Working Party of the EBMT. He is also the founder and current chairman of the International Academy for Clinical Hematology and a board member of the IFM. Dr. Mufti is also a fellow of the French National Academy of Medicine. In addition to publishing more than 100 peer-reviewed articles in the field of stem cell transplantation, leukemia, and myeloma, Dr. Mufti also serves as editor-in-chief of journals, mainly bone marrow transplantation and Clinical Hematology International. He also serves as editor, board member, and reviewer across numerous other reputable journals. I'm glad to introduce the lecture about the updates in the VOD, which is a common problem and distressing problem in the setting of bone marrow transplant. This is because of the situation of Dr. Moti. This lecture is going to be a recorded lecture, so we can enjoy this lecture, inshallah.
hi, Masal Khair, Assalamu alaikum. It is my great pleasure to be with you today as part of this successful event. And I'd like to start by thanking Dr. Abdeen and all the colleagues from the Jordanian Society of Hematology for the kind invitation that I appreciate. And hopefully, inshallah, next time we'll be with you in person. So for the next few minutes or so, I've been asked to discuss with you some of the recent advances in terms of veno-occlusive disease. Here are my disclosures. I don't think I need to spend a lot of time to explain to you and to this audience the complexity of the allogenic stem cell transplant procedure, where we know patient characteristics, comorbidities, disease features, remission status can play a role. The transplant platform, the choice of the conditioning regimen, the graft source, the type of donor are also crucial parameters. Of course, we have acute but also chronic GVHD in terms of prevention, but also treatment. But also we have to take into account the problematic of early complications, which are usually rare, but can be really very serious. And here I'd like to spend a few minutes discussing the different endothelial syndromes during stem cell transplantation. And on this slide, you have a sort of a summary about the endothelium insult and injuries related to the chemotherapy of the conditioning regimen, the cytokine storm generated by alloreactivity, but also the deleterious impact of GCSF, calcineurin inhibitors, etc. And all of them are creating a procoagulant status, an inflammatory response, increasing the permeability of the endothelium, leading to endothelial activation, but also endothelial dysfunction. And this would lead at some point to a clear pathology and syndromes that we can see after transplantation, leading to organ damage. Obviously, this could be subtle depending on the different capillary endothelial cells, but if we have a systemic capillary damage, this is where we have the capillary leak syndrome, the engraftment syndrome, thrombomicroangiopathy associated to transplant. If this damage is organ limited, actually in the liver we have VOD or SOS, in the lungs we have diffuse alveolar hemorrhage. We can have also in the brain the PRESS syndrome, in the kidneys, the TMA. So you can see it's not only about VOD, it's part of a global, I would say, syndrome, which is caused by endothelium injury. Now, going back to the causes of death after allotransplant, and you can see where I would like to go about these early but serious complications. This is a paper from almost 10 years ago, looking into the causes of death in more than 1,500 allotransplant patients. And you can see relapse, GVHD, infections, but you have also a small, not really small, 16% of other causes. So what are the other causes? They are listed here. And if you focus a little bit, you can see that in these other causes of death, we have liver VOD or SOS with renal failure, with multi-organ failure. So you can see usually all of these early complications like VOD are put in a mixed bag. And actually, when you look to the BMT registries, they are ignored at some point because it is under the umbrella of multi-organ failure. They don't fit in a specific category. And in order to further confirm this, with one of my young residents 3 or 4 years ago, we did a very detailed analysis of more than 200 patients with acute leukemia who died of multi-organ failure. So in the registry, in the EBMT registry, it was mentioned that these patients died of multi-organ failure. And we didn't have any other details. What was the trigger for multi-organ failure? And here is our biggest surprise, that we found 1/3 of these patients, 35% of multi-organ failure related deaths, are actually VOD. It was triggered by VOD, and most of it, 69%, was previously undiagnosed. So this is why we believe that a significant proportion of VOD patients are not really diagnosed, or they may be diagnosed very late. And it's not because the physicians didn't think about it, but because we know, and I'll come back to this, the complexity of the diagnostic criteria. For instance, 34% of these 70 cases were diagnosed according to the modified Seattle criteria. We had the late onset EBMT criteria, and some of them didn't meet any criteria. Also, we have also simultaneously other complications like acute GVHD. So that adds another level of complexity. So this is why we've been working in the last 15 years, actually, since 2009, 15 years, on trying to better understand, better categorize, better diagnose, and treat VOD. And you may remember in 2016, 8 years ago, we have published the EBMT, the new EBMT criteria for the diagnosis and management of VOD. Recently, this was in 2016, and the aim was to really improve on the historical criteria that we've been living with for more than 35 years. Recently, in 2023, less than 1 year ago, actually in April 2023, we have published the EBMT refined the criteria, because after 8 years of using the 2016 criteria, we have improved, and we had more, or a better granularity and better knowledge on how we should handle this. First of all, we tried to summarize the risk factors for VOD. These are the risk factors from 2016, and you can see we tried now to group them into 2 categories. The unmodifiable risk factors, the patient come with them and you can't do anything about it, and the modifiable risk factors, which would depend on the transplant physician, and the physician can decide how to handle this. And it's important because we believe it's crucial that we analyze carefully the risk factors for VOD before proceeding to transplant, because then we can mitigate the risk of VOD. And we have clarified some of these criteria by highlighting the issue of primary immune deficiency diagnosis, especially in children, the threshold for iron overload. We introduced treosulfan because treosulfan wasn't approved when we drafted the initial paper, but also now we know that GVHD prophylaxis is moving, especially with the introduction of post-cyclophosphamide, and then patients are receiving a lot of alkylating agent. And the more alkylating agent you give, the more actually endothelial injury you will see. So you can appreciate these risk factors. Everything that is modifiable, I think it needs to be taken into account, because you can play on the dose of busulfan, treosulfan, the use or not of methotrexate, etc. Now, what about the diagnostic criteria? In the 2016 criteria, we identified the classical VOD, less than 3 weeks, less than 21 days after transplant, but also the late onset, which 6 months, usually in the first 3 months. here it proved to be quite difficult because these criteria mandated the presence of all the different parameters. And we know that VOD is a highly dynamic process, and not all symptoms are present at the same time. That's one point. The other point, and you can see it here in red, that now we have some new methods like elastography, which can suggest, for instance, the presence or have some symptoms of VOD. Also, hemodynamical changes are now also can be used for this. And this is why we ended up refining these criteria by identifying 3 groups. The easy group, I would say, the proven, histologically proven. But obviously, we don't recommend to do liver biopsy all the time, and it's more difficult. Then on the left-hand side, you have the probable VOD, where if you meet 2 criteria, starting with 2 criteria like increase of bilirubin or painful hepatomegaly or weight gain, ascites, or ultrasound and or elastography suggestive of hepatic VOD, then you can suspect and you become alert how to handle this. And in the middle, you have the clinically well-established VOD where you have all the symptoms. So you can appreciate now that we believe that by introducing this probable category, we will be able to identify earlier the problem of VOD. And of course, I will show you later, the goal is to treat earlier. And hopefully, the introduction of elastography, I know it's not available everywhere, will further help to analyze or to confirm or to help for early diagnosis. Now, once you have made the diagnosis or suspected VOD, the question is about grading the severity. And again, in 2016, we have published these severity grading criteria, and they are quite easy, relatively straightforward. What we try to do here is really to refine their use, especially by being a little bit more precise when it comes to the kidney function, especially that we're treating patients who are older and older, and there are patients with comorbidities who do have some kidney dysfunction at baseline. So you can see we are refining all of these measures, and we insist on the idea that the severity grading criteria must be applied at the point of diagnosis. This is the best way to anticipate and actually intervene. Now, when it comes to multi-organ dysfunction, which we prefer to use compared to multi-organ failure, actually, we thought that we can use the SOFA sequential organ failure assessment scale that is already published since 20 years by our colleagues from the ICU. And it's relatively easy to use. And of course, we do consider that there is a multi-organ dysfunction if you have more than 2 organs being involved from the SOFA score with a score of more than 2. Obviously, we don't take into account the issue of the liver because that is the problem of the disease itself. So you can see today, and in the last 6 months, we have really introduced important changes that would help and allow to clearly identify early and intervene to treat VOD, risk factors, modifiable versus non-modifiable, introducing the probable diagnostic criteria, but also trying to refine the severity grading. And we need this because the outcome of VOD without treatment, especially severe and very severe VOD, is always dismal. more than 80% mortality. And it's even more complicated to manage on a daily basis because VOD rarely occurs alone. And you can see here a wide variety of complications, infectious complications, GVHD, but also the other actually endothelium syndromes, which can occur early after transplant. So it is actually a very complex situation when it comes to diagnosis. This is why vigilance and early intervention is crucial. So how to manage VOD? Today, the only approved drug which proved its efficacy is defibrotide. And defibrotide is well analyzed. It has been available now for many, many years, more than 2 decades. It has been approved in 2013, actually, by the European Medicine Agency. And it has an important protective role on the endothelial cells. And the approval came from this phase 3 trial published in Blood in 2016, compared to historical control group and showing, and these are patients really with severe VOD, really late stage, and they were matched into historical group, and there was a clear benefit for defibrotide. But the results were also confirmed in the International Compassionate Use Program. We published this already also in 2016. More than 700 patients analyzed, and actually we could reproduce the same results from the phase 3 registration trial. More recently, 4 or 5 years ago, we had the TIND study from the US, which is a large prospective, open label, single arm study, which included more than 1,000 patients, and actually 512 patients had hepatic VOD with multi-organ dysfunction. And the key learning from this TIND, for instance, is the impact of the timing of the initiation of the treatment. And you can see whether you consider those patients with multi-organ dysfunction or whether you consider the whole group, the window for the right intervention is usually within 48 hours and ideally within 24 hours, because then if you delay the intervention, actually the outcome is going to worsen. The other message and teaching we had from the TIND is that it may take time for patient to recover and be in complete remission. And this is why we should not stop the treatment very early, even if the patient is improving. Actually, we do recommend the required 3 weeks of treatment because improvement will continue over time. Here I'd like to show you the most recent data from a large French registry in more than 57 centers, a Defi France study, 53 centers, sorry, including children and pediatrics. And these are all patients that were treated with defibrotide. And you can see we have almost 800 patients included in the study and monitored and analyzed. 251 were treated for severe VOD, but also we have a group of patients who received it for prophylaxis, but also for VOD outside transplant, because we know we can see VOD outside transplant. And here I'd like to show you the characteristic of the patient who were treated for severe VOD. Actually, this is what you would expect in a transplant population, whether pediatric or adult. And this is, I think, in line with your practice in Jordan and in the region. What you can see here when it comes to the characteristics of the VOD, because we captured the symptoms, actually, none of these symptoms, whether in children or in adults, is present 100%. So that clearly highlights the complexity of diagnosis of VOD. Also, in adults, in 40% of the cases, we could already see multi-organ dysfunction. So you can see this is a very rapid dynamic phenomenon. The good news and this is really in relation with our recommendation and being very tough on applying some stringent rules, is that defibrotide was started immediately after suspecting the diagnosis. And you can see it's important because the CR rate by day 100, if you consider children or adults, is better if you intervene early. In yellow, this is the early intervention, severe versus very severe VOD in blue, and the results are always better. And this will translate into a survival benefit. And you can see again, there is a clear difference between severe and very severe. So early intervention is crucial. And I believe this is even very preeminent in the adult population, because obviously the adult patient have also other comorbidities. They are usually, children are quite resistant in general, and they can recover from complications. Adults, especially now we're treating more and more elderly patients, high risk refractory disease, some poor performance status. So I think it is important to pay attention to all this. What about the side effects? I think, as I mentioned, we've been using the drug now for more than 20 years. I think the safety profile is well known, well described, well established. One word of caution, please avoid using defibrotide at the same time if the patient is receiving heparin or other anticoagulation, because then you will increase the risk of hemorrhagic event. So please stop heparin when you're using defibrotide. So in conclusion, I hope I have convinced you that these endothelial syndromes are very serious early complications after transplant. They can be life-threatening. However, liver VOD can be expected. It's not something impossible if we use effective risk assessment and we are vigilant and we apply the effective differential diagnosis. It can be predicted if we use the refined EBMT severity grading, but also because these criteria, the refined criteria of EBMT, can enable enhanced vigilance and prompt intervention. And the idea and the goal is to avoid the catastrophic outcome, as I mentioned, 80% mortality without treatment or with late diagnosis. So with this, I'd like to thank you for your attention. I hope you will continue to enjoy this wonderful event, and congratulations to the society and the leadership. And I hope to meet with you in person in the near future. Thank you very much. Hi.
Of the syndrome. Because the lecture is recorded, I don't think so we have room for questions. But you can send your question via the messages, and we will forward it to Dr. Bot, inshallah. Dr. Muhammad Salama, you do have any comment? We cannot hear you, Dr. Muhammad Salama. If you have any comment. Yes. And if you have a comment, you cannot talk. If you have any issue with the microphone, you can write it down on the chat. Dr. Muhammad Salam is active participant in all the lectures. I think his input is very important. But I think we have technical issues in this.
We would like to see his comments in the chat box.
Yeah, we can receive it in the chat box.
He is not going to join the parent.
Max? انا كنت مودريتر عندي مش ميوت
So, good evening. Our next speaker is going to be talking about innovative approaches in the management of non-small cell lung cancer patients, what we got to learn. This is Dr. Maximilian Hockmeyer. He is the leader of the respiratory oncology unit in the Department of Respiratory and Critical Care Medicine and Clinic Floridosdorf in Vienna. He completed his lung training as a lung specialist in 2008 in the first lung department of Otto Wagner Hospital, and since then he has been in charge of the respiratory oncology unit. In addition to his clinical and scientific responsibilities, he was on the board of the Australian Society of Pulmonary from 2008 to 2014, and was a national delegate between 2011 and 2014. His scientific interest covered the entire field of pulmonary and numerous national and he has numerous national and international publications. Please join me and welcome Dr. Maximilian, and we'll listen to his presentation on lung cancer.
Many thanks. I'm sorry, my computer, and I have to present from my mobile phone. I hope it's working properly. I never had that before, but we will manage it. I hope you have my slides, so I hope you can present this from your side. Is this possible?
His slides, and we will go and he will talk about the slides. We are just waiting for your slide to come in.
Okay, then I will talk just a little bit already what I had to prepare in this situation. So we had huge advantages. We had huge advantages in non-small cell lung cancer. We had 20 years ago no improvement in overall survival in comparison 10 years later. So 10 years ago, it was a little bit better. And now we had just in the last 10 years, in the last decade, a doubling of the overall survival. And we saw this data, for example, at the ASCO this year in lung cancer, that there was a tremendously improvement in the situation. We treated in the past all patients similarly. So we treated all patients with lung cancer always with chemotherapy. When I started my education in Berlin in Charité, we treated all patients similarly with lung cancer with chemotherapy. Nowadays, we know to have to select patients based on their findings. So we need an NGS, we need biomarkers to select which patient need what in this situation. When you have the slides, tell me. I speak freely if necessary. Good. Please tell me, dear Chairman, when it's working.
You can keep talking if you want. You know.
Yeah, I can do it. I know my message, so everything is clear. So based on the findings that we have huge improvements on the one side of targeted therapy, we have EGFR, ALK, ROS1, NTRK, BRAF, MET-skipping mutation, and HER2 mutation, for example, where we have huge developments. On the other hand, on the side of immunotherapy, PD-1, PD-L1 inhibitors, and in combination with chemotherapy, we have huge developments. So in the moment in stage 4, we separate between chemotherapy and immunotherapy or immunotherapy alone, plus minus targeted therapy. We have the ADCs where we have a lot of new advantages also in the setting. We are trying now to combine also ADCs with immunotherapy, ADCs with targeted therapy in this situation. And newly, we also have the possibility to use bispecific antibodies in this situation. So in lung cancer, we have 5 different compounds that we can use. Based on the histological finding, we select which patient needs what. When you don't perform an NGS probably or not so often, then you will see sometimes that you have no target, and sometimes we are finding targets. So when we look at our registry and also the data, international data, we see that about 40% of the patients do not show anything in the NGS, but in the NGS reports, in 60% of the patients, we find something. And therefore, where we can select patients based on these findings in this situation. So we find EGFR mutated patients, we find KRAS, but KRAS G12C is druggable, KRAS non-G12C is not druggable. But we can generally say that the survival in this situation for these patients is worse. So we can see, based on the finding, we know EGFR mutated patients do not respond perfectly on immunotherapy in this situation. So there are some things that we can learn from the NGS. We have a registry in Austria where we can test all patients with NGS in the beginning. We are, unfortunately, in Austria, we have no lung cancer screening. So we see a lot of patients still in stage 4 or later stage 3. So I would say 3/4 are in the local advanced or advanced stage. I don't know how it is in Jordan, where you have perhaps 1/4. We have only 1/4 really the early stage patients, unfortunately. We are very good in the diagnosis. We are taking 15 days for the diagnosis from the first contact, 10 days normally till the biopsy. And after 5 days, we have the NGS report, also the PD-L1 staining. So here we are relatively fast. Based on the findings, if somebody has an early stage or a later stage, there are no differences in terms of PD-L1 staining. There is no difference in the NGS findings. So we can generally say, I thought initially early stage will have, for example, less difference in PD-L1 staining, or we will have in early stage more EGFR mutated patients. There's, from our findings, no differences in these data. When we look at our patients, 50% have in the NGS something, 50% have nothing. So it makes sense to test with NGS. Why do I point out this so exactly? I want to show that when you select patients and you give the patient the right drug, then the patient is living longer. But when you give an EGFR mutated patient just immunotherapy, even PD-L1 staining is high, the patient will not respond that well. On the other hand, when you have a patient with high PD-L1 staining and this patient has an EGFR mutation and you don't give an EGFR TKI, the patient will not survive that long. So selecting the patient is an important issue. Now I would like to show some CT scans, how the development is. Is there a chance to see the slides already? It doesn't seem like that. Good.
The slide arrived, okay, but you downloading. Just give us a few seconds.
No, then I keep on talking. It's my first time that I have to
enjoying it
in this situation. I don't know why my computer doesn't like your WebEx meeting. Normally it works.
Well, I figured out like WebEx is not that friendly between different PCs,
Yeah. My iPhone is liked, my computer is not liked. So perhaps there are some differences.
Like, yeah, the windows are not going really very well with WebEx. Okay, so they have some issues with downloading the slides. Yeah.
Okay, then I keep on talking. And now I tried it on the computer. Perhaps it's working now. But generally, I wanted to say that we had when did we switch generally from chemo IO in later stages also to early stages in the situation? We switched our strategy when we saw initially our patients with stage 4 patients, and we had some patients which responded enormously. And I wanted to show you a case with a T4N3 disease where we had a huge tumor. And the radiosurgeon, the radiotherapist said, this tumor is too big for radiotherapy. The surgeon said, this is impossible to perform surgery in this situation. So we induced the patient with a T4 and 3 situation with chemo-IO, with the Keynote 189 regimen, and we saw that the tumor completely disappeared on this treatment. And is it now necessary to perform local therapy also when you have a nearly complete remission, even it's a localized, extremely huge disease in this situation? And we decided here in this case that we went for surgery, and then we didn't find any tumor anymore. So even it's not allowed to do surgery in patients, you would not expect that these patients will respond. We see, or you could heal them. We saw in the when we started Keynote 189 patients with huge responses in this situation. We're using Keynote 189 since a long time. We are using chemo-IO with chemotherapy and pembrolizumab, and what was astonishing on the one hand, the overall survival, but the remission rates are so high. We have in PD-L1 high staining patients remission rates of 62% in the Keynote 189 trial. Even in PD-L1 negatives, we have 1/3 of the patients are responding. So we're doubling the response rates. Why should we not use this approved regimen in stage 4, also in the early stage setting? And this is something I wanted to share with you, some cases where we made our first experience that we had an oligometastatic disease, went to surgery or radiotherapy in these patients. And we saw the pathological report, and sometimes we had a complete pathological response. Was really astonishing. And this is the reason why we said we want to move on in this strategy. Then we had the data from the adjuvant situation that we have in adjuvant setting, not really good outcomes. With adjuvant chemotherapy alone, we're improving after 5 years the overall survival for 5%. When we even go for the YALT trial, after 7.5 months, after 7.5 years, we completely lose the overall survival. So after 7.5 years, the patients who are still survivors lost their better outcome based on the chemotherapy. So with chemotherapy alone, we are not happy at all. And this is the reason why we are moving these new strategies into the early stage setting. We have on the one hand the targeted therapy options. We have the ADAURA trial where we are using in EGFR mutated patients osimertinib in the adjuvant setting. We saw at the ASCO the data that we have an overall survival benefit, but we are using, for example, osimertinib also in the neoadjuvant setting with the NeoDAURA trial, or we saw the positive results with LAURA that it's better to use osimertinib in the early setting in the situation. So we are allowed to use in this setting with ADAURA. Also, I'm co-author of the ALINA trial that we can use in the adjuvant setting, ALK translocated patient adding alectinib, leading to a much better survival and disease-free survival. So why should we not use also chemo-IO in this setting in early stage? And then I just checked what I wanted to present, and I showed a case, a T4N2 disease, where we did a lobectomy after Keynote 189 situation, and the pathologist was calling me in 2020 and told me everything is away. Was there even a tumor? And I said the biopsy was done in another hospital, and he didn't believe me initially that and said you operated and you did surgery in a patient who has no tumor. But then we saw that there was a tumor. We checked everything, and since 2020, it's clear that we should perform in patients with, in this situation, a chemo-IO as an induction treatment. What is always the problem is how many patients getting chemo after chemoradiotherapy, chemoimmunotherapy, how many patients do we lose? But when you select the patients carefully, it's the possibility that we don't lose patients for a local ablative therapy. And generally, I have to say, we are getting less patients for the Pacific regimen, we are more or less using more and more the keynote strategy in this situation. This was leading now to the slides of the keynote 671 trial, where in this situation, chemotherapy in combination with pembrolizumab was given. It was compared. Now the slides are coming. Perfect. I see my slides. Can you move to slide number 42, please?
Okay, so we'll go to 42. So almost you are done with the slides.
Yeah. Now some are hidden, some are not hidden. So I don't know. So when you go to slide number 42.
Yes, we are there.
Yeah. So this is fine. One slide up.
One
to
slide
see
up.
Another one up.
41 or 43?
You have another number. Slide. Sorry. Another one up. So, yeah, here you see the keynote 671 trial. Can you go in the presenting mode? Then you are losing the slides that I didn't want to show. So here you see the keynote 671 patients. On the left side, you can see patients that were generally operable. But the problem is, we know that in N2 disease, we say they are generally operable, but at the end, we are always doing a neoadjuvant treatment. But these patients received chemotherapy or chemotherapy plus pembrolizumab. And here, the patients were stratified based on PD-L1 staining, etc. Next slide, please. Here you can see then how many patients did not receive immunotherapy in this situation, did not receive surgery. And in the study, 80% went into the surgery. But we know that other patients received surgery somewhere else. Some patients received radiotherapy. So at the end, only extremely small proportion of 2 or 3% of the patients did not receive a localized therapy. This is shown in pink in the third column here in the slides. Next slide, please. In the trial, we also saw the huge difference in event-free survival. You see a hazard ratio of 0.58. This is extraordinary. In the trial, it was not selected between EGFR and ALK translocated patients. You see, even when you don't select in this situation, that the event-free survival is extremely good, hazard ratio 0.58. I would say when you select the patients more carefully with EGFR and ALK translocation ROS1, then the data from our side, where we treated more than 150 patients already with this regimen, our personal data we will present it at the ESMO, are even better in this situation. Next slide, please. We see this difference in all kinds of patients. We see the difference in no difference between clinical findings, no difference between smokers, never smokers, no difference in the lymph node stage, PD-L1 staining. So also the PD-L1 positive and negative ones are getting better. Next slide, please. What we also see is that the overall survival already now, even the data after 24 months for all patients are not already so mature, but they are mature enough to do statistically analysis, and you see an overall survival benefit in this situation. Sorry, next slide. Here you can see the official slides from ESMO, where you see already the overall survival benefit in this situation. Next slide, please. Here you should see here is the ESMO presentation, where you can see already the clear overall survival benefit for all patients in this situation. Next slide, please. An important endpoint is always pathological complete remission and major pathological remission, something we normally didn't see so much before. But when you have a pathological complete remission, it's an extremely good outcome. You could say here now 20%. But when you select patients, here are EGFR, ALK translocated patients also included. When you select the patients carefully, we are coming here for 40% of the patients are showing a PCR. And from our personal data, also 55% have an MPR in this situation. Next slide, please. This next slide is showing that when you have a PCR, this is the yellow curve on the top, the outcome of this patient is extraordinary. And from our side, these patients with a PCR never died based on tumor. Some had also a COPD or something like that. But normally the outcome of this PCR patient is really extraordinary. Please click twice because then it's too long. Twice click, please. Yeah. So at the end, what is the right strategy? Neoadjuvant surgery, surgery, adjuvant, or neoadjuvant surgery followed by adjuvant. So I'm a clear fan of the perioperative. This is the strategy, neoadjuvant surgery and adjuvant strategy, to really use the immunotherapy upfront, but also adjuvant. Next slide, please. What we always try to compare trials. I know it's not allowed, but at the end we do it and compare trials. For example, the Keynote 671 trial is showing an overall survival benefit already now. Even the data are not comparable to the others, but the others could not show something like that. Next slide, please. Here you can see patients with neoadjuvant strategy, checkmate 816. For sure, a relatively easy strategy. You give 3 times chemotherapy plus nivolumab, and then the immunotherapy is done. But it's not an adjuvant setting. And I will show you then the 770 trial, where also perioperative nivolumab was given. The outcome of these patients is even better. Next slide, please. The adjuvant strategy with IMpower 010 on the left side and Keynote 091 are generally strategies that you can do. But you see, in comparison to the neoadjuvant strategy, worse outcome for generally. But you have here clearly selected patients. Neoadjuvant means that you can treat all patients. But in the adjuvant setting, how many patients are not receiving perhaps chemotherapy, then they don't fit into this regimen. They never get relatively late the immunotherapy in this situation. Please click now, sometimes because I will have to skip time. Please click to a lot of 3 times, because when I don't click, I cannot. Next time, please. Next. Here I only wanted, yeah. Next one again, because I think we are out of time and I have to select carefully the slides. Next slide, please. Yeah, this is perfect. No, one back again. Here you can see the neoadjuvant strategies in generally. And you see here the neoadjuvant strategies for all. If you use left upper with pembrolizumab, the Keynote 671, on the down the 770, on the right side the Aegean, where I'm also co-author of the study. We see that the neoadjuvant strategy is always better in comparison to chemotherapy alone, and the hazard ratio are clearly in favor. No study could show till ESMO an overall survival benefit or till now. Next slide. And here we could see already now at ESMO with the Keynote 671 with pembrolizumab, the first overall survival benefit. Therefore, Garasino gave a golden medal to this regimen because it was a clear overall survival now. Next slide, please. To compare the perioperative or only neoadjuvant strategy, here we can compare nivolumab as a single strategy with only neoadjuvant on the left side, on the right side perioperative with nivolumab. And you see a difference in the hazard ratio of 0.10. I know it's not allowed to do something like that, but you can clearly see that there's a clear trend towards the perioperative strategy. Next slide, please. We are all strategies generally the same. Marina Garasino said yes, but I have still to announce that Keynote 671 is the only trial that is showing an overall survival benefit. But she said yes. Next slide, please. Should we treat patients in stage 2? Yes. For all studies, a clear advantage if I take Aegean with durvalumab, nivolumab with 770 or pembrolizumab, here's a clear favor in terms of event-free survival for all immunotherapy in these situations. Next, please. Should we go for neoadjuvant strategies in the PD-L1 negative ones? Also a clear yes, like you can see here. Here, all patients have a clear favor for the neoadjuvant strategy in this situation. Next slide, please. What is a problem when you start to use these strategies? You have to be aware that sometimes the responses are relatively tricky to decide what is right or what is wrong. Because when you do a restaging too early, you can see with the blow arrow that there can happen a pseudo progression in the situation. And when you do the restaging after 2 or 3 months, then you can see a pseudo progression and select the patients in the wrong way. Next slide, please. Here I want to share a case. On the part on the top, you see the baseline. Down, you see the 12-week follow-up. Here's a tumor where you would never say this patient is operable. You would never say this tumor is able to do a curative intent of radiotherapy in combination with chemotherapy. And we did neoadjuvant the pembrolizumab plus chemotherapy, and you see down at after 12 weeks, you have a hole there, and PET-CT is still positive. On the right bottom, you can see still some activity in PET-CT. Based on the RECIST criteria, you have a PCR, you have a PR, you have a partial remission. The tumor size changed a little bit, and then we said we are going for surgery based on this cavitation. And when we did the surgery, we had a P0 N0 situation. Patient was KRAS G12C positive, but had no druggable target in terms of EGFR, ROS1, or something else. So when we select the patients carefully, it's much, much better. Next slide, please. Also here, a case baseline on the top, then down the restaging. You see a tumor decreased, half partial remission, and we did surgery. And when we did surgery, we saw also here a T0 N0 situation. So the CT findings are sometimes misleading. You think you have a partial remission, there will be some tumor cells, but it's complete remission, and this is only something a pathologist can show us. Next slide, please. Here you can see 2 different tumors after neoadjuvant chemo IO. Left, still 60% viable tumor, right, CPR. So extremely difficult to decide it based on the PET-CT or CT finding, what is the outcome in terms of pathology. Sometimes we also see sarcoid-like reactions in the lymph node. The primome is decreasing, but lymph nodes are still there. And this makes the interpretation relatively difficult. Next slide, please. We are publishing this data in European Journal of Medicine. When you go in the middle of the slide, non-nodal immune flare. You see here a tumor on the left side initially, and then after immunochemotherapy, you just have a flaring of the lymph nodes, and there's no tumor growth. The tumor completely disappeared. So sometimes you have a mixture. So the interpretation of this CT scan is really, really difficult. And we are coming to the end, just the last 5 slides. Next slide, please. Here is a tumor left located, completely of occlusion of the left main bronchus, PD-L1 staining 1%, T4 N0 M0. Normally, we would say this is a classical chemoradiotherapy strategy, but the patient wanted to have surgery, so we said, let's do neoadjuvant, and even a pneumonectomy we would wanted to avoid also in this situation. So you see here the tumor is occluding the left main bronchus completely. So we went for the Keynote 671 regimen. Next slide, please. And you see an extraordinary remission of the tumor. Here it's clear when the tumor completely disappears, then you have a PCR. But is it for sure a complete PCR, or is it just a major pathological response? Is there still some tumor left? And here we went, before we did the surgery, next slide please, we went for the bronchoscopy. And now I hope when you click once, then you see another click, then you see the bronchoscopy that we performed. No, it didn't work. So I only wanted to show that after this strategy, the tumor completely disappeared in this situation. Next, yeah, here is fine. Here is fine. This one slide back, please. This is a patient where we also went for chemo IO, partial remission based on the CT findings. Next slide, please. Here we found still left 10% viable tumor cells, via 10%. So we have a major pathological response. We went for adjuvant pembrolizumab for 9 months. This is now my last slide, and I summarize lung cancer. Next slide, please. Summary. Lung cancer is a treatment, not one size fits all. Each case is unique, and we have to treat patients individually based on their personal wishes, NGS, PD-L1 staining, and comorbidities. And the treatment strategies that we had from later stage, they're moving to early stage. And at the end, there's a photo from my team just to show you how it works. Yeah, this is my team who are working, and I am allowed to talk smart. Thank you.
Thank you, Dr. Maximilian. The floor is now open for questions.
I'm happy that this lecture is over because it was so crazy.
Yes. Yeah, this is very interesting, and I really applaud you for, you know, giving half the lecture without a slide, you know, from the top of your head. Okay, so, you know, it's a hot topic in lung cancer, but let me ask you this question, you know, so for the, like, you know, how would you choose to give neoadjuvant, you know, immunotherapy versus, okay, neoadjuvant only versus, like, you know, nivolumab, or, you know, as the peer study, pembrolizumab, and then decide to give atezolizumab based on CR versus going to the perioperative. You know, the perioperative, you know, trial solved a puzzle for us. Like, you know, when you have two different immunotherapies, you know, to give as a neoadjuvant and, you know, as an adjuvant. So how do you really compare these two, like, you know, two approaches?
So when we look at the nivolumab trials, generally the 816 trial, we see in the whole group, we see no overall survival benefit as an important endpoint. And we see in all in the selected patients in the PCR group, we see an overall survival benefit, but we don't see a difference in overall survival for the whole group. When we look at the pembrolizumab study with perioperative strategies, we clearly see an overall survival benefit. So when I have to choose as a patient, I go for the overall survival benefit. For sure, there are some patients probably that have an advantage only from the neoadjuvant strategy, but we cannot select in the moment. Is it really only the PCR group that they don't need perhaps no adjuvant treatment, or do they really don't need it for the future? We cannot answer this question in a moment. So from my side, I'm treating patients when they tolerate the treatment well. I'm going for all patients for the perioperative strategy. For sure, I'm not the payer. I don't have to pay for the treatment. For sure, I don't have to rule the hospital based on the seats, how many resources you have. But when I have to choose, in Austria, it's possible to treat all patients, also perioperative. I go for the perioperative strategy. Clearly, and here Pembro based on the overall survival benefit, but we are selecting the patients. An adjuvant with Empower or Keynote is extremely rarely used, at least in our center. When we do surgery and then we see, the staging is higher than we expected, then we go for adjuvant.
Okay. Any other question? So do you need to do EGFR and ALK testing before you're going for the new adjuvant?
So I was so happy. I had this meeting yesterday in the Gulf region, and a surgeon said, we want to have in early stage an NGS test. I was really astonished by this surgeon that he said something like that. I want to have PD-L1 and NGS. On the other hand, when you don't get it, it makes no sense. So it doesn't, when you don't get it, I think the Keynote 671 trial was not based on the biomarker findings. So based on this Keynote 671, the biomarker selection is not clearly needed, but when you have it, it's a good sign and a good situation to select. We have in our center 3 neoadjuvant targeted therapy studies for ALK, EGFR, like NeoDaura, and also for RET. So for studies reasons and also label reasons, we need here the NGS test also for early stage.
You know, we're using in our center nivolumab. So, you know, as a new adjuvant, we didn't go really for the perioperative, the whole trial yet. But, you know, we do the EGFR and ALK for all the patients before giving them chemo IO. If they are EGFR or ALK positive, I will give them only neoadjuvant chemo, you know, rather than chemo IO. Do you think if you have the pembrolizumab, you will go with the pembrolizumab, right?
Yeah, the problem I have with Nivo chemotherapy is a strategy I don't use in stage 4 situations. Why should this only work in early stage? We did not see for these patients in early stage an overall survival benefit. This is the reason why we use Pembro in this situation.
Yeah,
so
but they surprise you always with the result. Look at the Kerala study, you know, the patients who are more than 50, PD-L1 more than 50%, they didn't do as good as less than 50%, you know. So they surprised us with this.
Absolutely. Mm-hmm. But I understand based on insurance payings, etc., it's necessary to find the right strategy for each country. But we are using Pembro generally in whole Austria already now in this situation. And for sure, when the patient is not willing to show up so much, but the adjuvant, the perioperative strategy, when you give Pembro all 6 weeks, it's not so intense based on the timing for the patient also.
Yeah, I really, what you said is thought-provoking. You know, the really Nivo chemo didn't work that much in stage 4. Now, but you know, you see a very good, you know, response and activity in the early stage. You know, pembrolizumab and chemotherapy or pembrolizumab as a single agent, they were very good, you know, and you know, stage 4. Probably they are doing good in the early stage. So this is really thought-provoking.
Yeah, you're completely right. And I think we have no head-to-head comparison. And when you use Nivo, you're not wrong. This is just an interpretation, and you're also fine with this strategy.
So my last question, unless somebody else has a question, what would you do for the patients who you gave the adjuvant chemo-immuno, and you know, by the time you did imaging, you find progression, local progression in the imaging, you know, increase in the size of the lymph node or increase in the size of the mass without, you know, distant metastasis?
Then normally in the past, we went for rebiopsy, especially when the tumor on itself went down, but the lymph nodes were increasing. We went for rebiopsy and checked if we have a sarcoid-like reaction or is it just an inflammation reaction. When the patient is still, even there's a progression, able to do surgery, we go for surgery. When surgery is not possible, then we go for radiotherapy and try the local treatment still. For sure, when the patient is developing metastasis, then you are under trouble, and this is the worst situation. But from our side, when you go for 3 months of treatment, it's extremely rare that the patient develop metastasis in this situation. I remember about 3 or 4 patients, so I would say 2 or 3% of the patients could happen that. But this is a horrible situation for the patient with a horrible prognosis. And I think this is a disease we could not do anything in this situation.
Yeah, we just have a patient like this. This is why I asked the question. You know? And we plan to give.
For the biomarker, when we check STK11, keep 1 or something, I would expect something aggressive here in this situation.
Yes. So it seems you need biomarkers. You know, maybe you will need biomarkers at the early stage. Anyway, I will not hold you, thank you for this great presentation. And,
Thank you.
Talk from your head and this interesting information. And I think by your lecture here will end the first day of our conference. Thank you, and we thank all our supporters for this.
Thank you. Goodbye.
Thank you.